technological advances, especially in the new millennium, in lot of allied disciplines of surgery improved the patient outcomes. Like radiology, the imaging, the amount it have progressed has made radiologies a key factor in confirming a diagnosis, at times blunting our clinical senses. And also we have to their waiting lists sometimes to get appointments. And the biomedical engineer didn't stop there. They made the radiologists interventional, taking a huge chunk of surgery from us. And today there's a dedicated talk from them, and I have to chair that. And also they made some physicians interventional, especially the medical gastroenterologists. I think Chaturanga would agree with me. And also the cardiologists. But I have no argument that this has improved patient outcome. There's no argument on that, in spite that we have lost our hierarchy. And just to share a photograph how a surgeon felt about this, losing the kingdom, and many more out of theater. But nevertheless, the technological improvements, in spite of adding a lot of costs for healthcare, but has enabled surgeons to do whatever minimal access they do into a different dimension. And these are, of course, also known as keyhole surgery. And initially it was available only for cholecystectomy, maybe appendicectomy. But now a lot of advanced procedures can be done through a keyhole. And to share some of the work that we do at Peradeniya, and this surgery that I did with Arinda, it's a right hepatectomy, and you can see how you can work on the portal vein and get the branches ligated. And then same patient working on the IVC to get the draining hepatic veins. So this view, I think it's not possible actually with open surgery. There's so much of clarity with magnification and zooming in. And then pancreatic work, you can see here that there's a large tumor in the, sorry, I don't have pointer. But anyway, you can see that there's a large tumor in the body and tail of the pancreas. And the last bit of we did a distal pancreatectomy with an in-block splenectomy, and that's the splenic vein being ligated, and the splenic artery. In this case, we had to go behind the pancreas because the tumor was so bulky, but the pancreas is lifted off the retroperitoneum, and both vessels are dealt. And then, so that's clipping the splenic artery. And division of the spleen at the pancreas at the neck with bipolar diathermy and ultrasonic dissector. So these are all technological advances. Without these, it's impossible to do actually major laparoscopic surgery, and also things like staplers. And this the sort of later part of Whipple's, you can see the stomach being stapled, and that's the pancreas being lifted off of the portal vein and to be divided by the harmonic. And getting into some surgeries in the chest, this is a large retrosternal goiter, which would generally need a median sternotomy. But this one also we managed to get the scope into the chest and do a thoracoscopic resection. And you can see we are working on the azygous vein and the right brachiocephalic and the superior vena cava. The good thing is that there are no major vessels coming into the goiter from the chest, because all the supply comes from the neck, which is being dealt when you do the neck part before we get into the chest. So it's just a matter of working around with, again, energy sources to complete the dissection and to remove the specimen. It's not necessary to open the chest, because through the neck incision, you can see my SR sending his hand under the major veins. So we are just helping him to grab, and it was taken off through the neck, so without any chest incisions. And again, thoracolaparoscopic uvectomy, you can see the plasters on the both sides in the chest without any thoracotomy or or laparotomy, and to compare the trauma of excess, if you just take the plaster size as the time taken and the trauma of excess to compare, you have a huge plaster in the neck, which is over the central line of the anesthetist. And the blunt esophageectomy, the Oringers also we do now with the scope guidance, where you can go through the hiatus. So here there is no thoracoscopy, it's all through laparotomy and through the hiatus going into the chest. And out of the procedures that we do in the chest, just to elaborate two interesting cases of sympathectomy. We generally do the sympathectomy for hyperhidrosis, but there's one person with a phantom limb. He had a above elbow amputation, and he had this phantom limb, and the problem was he was getting severe cramping pain in the hand, so he couldn't even sleep. And once all the measures failed, he was referred to me for this. I was not sure whether it will work or no, but we did the sympathectomy, and quite interestingly, his phantom, the arm and the forearm disappeared, but the hand still remains there, but it doesn't have the cramping contractions. Only explanation I can give is that he has lost the phantom forearm, which has the muscles to contract the hand, and so the phantom hand is not contracting. He can sleep. And why the hand didn't disappear? The only explanation I can think is of course, the hand is more well represented in the brain. So maybe the strong memories we can easily forget. So this may be evidence that the mind may outlast the physics. And then another one for cardiac arrhythmia, as a cardiologist asked me whether I could denervate the sympathetic supply to the heart. I was just shocked. I asked why. Because the child was suffering of some episodic arrhythmia with a risk of dying at any time. Her mother has died of the same condition. But he wanted me to take out the stellate ganglion. So we are usually we preserve the stellate, because in a sympathetic, if you take the stellate, they end up in a harness, and it's in the neck. But my SR did some reference, and he said dividing the bottom half of the stellate is adequate for this purpose. So we went into the chest and took teeth 2, 3, 4, and gently went onto the neck along the chain, and so that's a stellate. And this is a picture from the monitor that the stellate was well identified. And then we actually divided the bottom half, and the child is still doing well. And also now biomedical engineers have introduced the robot, and he's a slave of surgeon. The surgeon can operate, and the robot will take commands. But I'm just getting suspicious that this is also the beginning of another conspiracy. With the control of the biomedical engineers or the engineers on the cyberspace, I think the fluent people who fly to other countries for surgery, the surgeon can operate from another country, transatlantic, in a patient in Sri Lanka in future. But that's not my worry. So we have seen how technology has taken a long mile. And from the beginning of millennium, 1 decade, all the improvements were actually due to the information technology. It's very strong now. Now the engineers have moved into artificial intelligence, taking away a lot of human jobs. Supermarket outlets, world first table tennis player losing to a robotic table tennis player, and self-driven cars. If this come, the drivers, motor car examiners, and the traffic police will lose their jobs. But that is also not my worry. But will they make the robo autonomous? I think they can, because if you can make a self-driven car to drive in Sri Lanka, or for that matter in India, it's so much of unexpected challenges coming with the fixed anatomy. I think a robot can operate without any problem. So one day we might get the reverse. Now we have the slave robot, but in future, are we going to see a master robot and a slave surgeon? They are producing all artificial parts for us. I'll take a little back into the history. As a registrar, I have assisted, I'm sure Dr. Nias would have also assisted for the mitral valvotomy, where you have a bursting suture in the atrium, make a small step, the surgeon puts the finger through and does it, because you can't stop the heart those days. And it was more exciting for me to assist ASD closure under hypothermia, where the patient is, after anesthesia, immersed in ice bath, and the chest is open, heart is stopped, and you have, I can remember it's 5 or 7 minutes, because under hypothermia, you can go on a more prolonged situation with no circulation. And the surgeon opens the atrium, sutures the thing and closes, and within that time, you have to come out. But now, the biomedical engineer has given us the heart-lung machine, and you can do elegant surgery in amount of hours, long hours. So it's a artificial heart and lung. And so is dialysis. Even at this moment, the biomedical engineers are working on artificial organs, which will be a challenge to the hierarchy of transplant surgeons one day. So, so one day we may see hybrid humans, artificial and natural, and we may get sick of living one day, I think, because life will be prolonged. But I think it's some time to come. And still out of this, we still have preserved nature. So I'll take you to end up my lecture out of this artificial and technological world into nature. And I usually end up my slide with this. Janaka gave me this photo. I do, you know him in God. And when I show this, I usually say this is like the surgical team, the surgeon taking the dive, anesthetist having a close look, and radiologist and physician having a nice time. And the one who is coming to come in is like Professor Kodikar, the judicial expert. We generally just don't like them to come into our work because that means the patient is over. So but they are carefully watching us. Dr. Yas, you have to be very careful of this. But anyway, now things have reversed. I think more often than not, some other person takes a dive while the surgeon just observes. Loss of hierarchy. Thank you.
Thanks, Professor Kalkatia, for your elaborative and very interesting lecture, giving us something to think about in the future. If there are any questions, we can take them at the end. Can you move on to the next lecture, please?
Yes. Next lecture is by Professor Sarachandra Kodikara. He is a attorney at law as well as a doctor and now professor in forensic medicine. He is a chair professor of forensic medicine and consultant in forensic medicine and former head of the Department of Forensic Medicine at Faculty of Medicine, University of Peradeniya. And he is qualified from University of Peradeniya and then Doctor of Medicine in MD Forensic Medicine from University of Colombo and Diploma in Legal Medicine from University of Colombo as well. He is an attorney at law of Supreme Court of Sri Lanka with honors and notary public and commissioner of oath. And a clinical fellow in forensic pathology and research fellow in forensic pathology in University of Toronto. And he has published 30 peer-reviewed journal articles as full papers and 40 abstract publications. And he has 10 international publications, presentations as well. In addition, he has contributed to 2 chapters of the textbooks and a series of fiction books in forensic medicine, which is Nihanda Knows Sakshi, and a textbook in forensic medicine and a novel, national and international awards. He has won 6 awards and he's a feature writer to national newspapers. And not only that, he has contributed to a forensic teledrama series in capacity of forensic director, screenwriter, and as an actor as well, which is Teveni Asa. So may I invite Professor Sarachandra Kodikara for the his presentation with medical legal aspects in trauma in private sector.
members from the head table, ladies and gentlemen, good morning and welcome to the fascinating world of forensic medicine. My topic is medical legal aspects of patients with trauma in private sector. Why we should learn about this topic? You may have a patient in private sector, a patient with trauma. You do not know he may have a cause of action. In other words, a reason to file a case in courts. You do not know. That will arise in future. That may be a criminal case, a civil case, or maybe a workman compensation case. Therefore, as a surgeon, as a doctor, you have to be careful about future. What are the circumstances of your patient? Trauma due to accidental by self, by another person, accident by animal, and accident at workplace. There are certain other circumstances, self-induced or caused by friendly hand, attempted suicide, and attempted murder. All the circumstances I have highlighted in red could be ended up in court cases. Why? Accident by self could damage public property or any other person. Accident by another person could be negligence. Accident by animal, the owner of the animal could be prosecuted. So you have to give evidence of the patient. The workplace accident, you have to submit a report to workmen compensation courts. Of course, self-inflicted injuries and friendly hand injuries are not prosecuted in the country. Attempted suicide, not prosecuted, but attempted homicide invariably prosecuted in the magistrates and high courts. So be careful. How do you understand this injury? A laceration, abrasion, or a laceration or cut injury or a stab injury. Any guesses from audience? So most of the doctors identify this as a laceration. If you identify this as a pure laceration, that is injustice to the patient and the society. Because you see a center hole and some amount of blackening just adjacent to the center hole. So this is an entry wound of a rifle firearm, a bullet from a distant range. So if you describe this in such a manner that you serve justice. You see some injuries on the neck, simply abrasions and contusions. How do you understand these injuries? So what is the severity of injuries? So most of the doctors identify this as simple abrasion and simple contusion, but concentrate where it is. It is on the neck. So this is the act is the attempted manual strangulation, which is amount to attempted murder. And simple laceration, simple contusion is a punishable offense, but negligible. When it comes to neck, the punishment is 20 years rigorous imprisonment. So if you identify it correctly, you serve justice. Otherwise, it's the injustice to the society and the patient. The medical legal management of a patient with trauma in private sector. So this is the basic medical legal management of such a patient, taking a medical legal history, not a clinical history, injury description, sketching and photos, collection of trace evidence and maintain chain of custody, and assessment of drunkenness. Since not a judicial medical officer is involved in such cases, these 4 steps of management are yours. Then you have to inform police if there is a if there is any suspicion, issuing of medical certificates to courts, do necessary referrals, giving cause of death and requesting inquest, and documentation and confidentiality maintenance. So we'll take one by one. The importance of the medical legal history is utmost importance. Usually, hearsay evidence is not admissible in courts. A says to B, I was assaulted by X. X goes to courts and tell A told me that he was assaulted by B. The judge will kick B X because the third party evidence is not admissible in courts. This is from lay people perspectives. But when it comes to doctors, you have certain privileges as expert witnesses. Your history is admissible in court of law. A good example is, not related to trauma, 8-year-old girl got into the swimming club of Otters pool. She got into the swimming pool of the Otters Club, and she was gravely sexually abused by a 60-year-old man, just touched. You know, touching leave no injuries. The girl came to me. I took a very long history. She described the color of swimming cap, the color of swimming goggles, and the color of swimming pants, and the tattoo on the man. So no physical findings at all. I submitted my history to courts. The court used my history to corroborate her statement given to police and the courts. Without any eyewitnesses evidence, without any physical medical evidence, the court convicted this man based upon those three histories because it was corroborated. See the gravity of your medical legal history can be used to convict or acquit a person. The importance of injury description and sketching and photos when you see a traumatic patient in private sector. You may identify this as a cut injury or stab injury, but if you do more description, like the corner edge is sharp, is pointed, the edges are sharp, and this edge is blunt. So it gives some impression to the judge, the defense counsel, and the prosecution counsel about the nature of the weapon. And that will corroborate, your description will corroborate the exact weapon in courts. You will give valuable piece of evidence for a fair administration of justice in courts. But if you describe just a cut or a stab, that may drop the case in courts. Res ipsa loquitur, the fact speaks for itself. You can see a woman with burn injuries. Burns are brown in color. So if you describe brown in color, the people in courts will make opinion due to acetic acid. And you can see on the chest, there are drip marks, and on the right upper arm, splash marks. So it's due to moist burn. So liquid acetic acid, and you describe on the right hand, right forearm, the dripping is like when in this position, it is vertical. So she has defended. So this is an assault. So it gives valuable information to prove the case in the court of law. The boyfriend called the girlfriend to come closer to Candy Milk Bar, and she was taken to Amphitheater, an abandoned house. She was tightened against the bed, and the boyfriend did a gang rape. And this girl came to me. You can see this is forearm. At the very center, you see a small abrasion, which I noticed during my examination. How this helped to prove the case in courts? The boy said his plea was consent. So I submitted this photo with the injury description to courts. There was a tiny abrasion on the right forearm, healing, dated to 2 days back. And I made the opinion that this was due to binding against the bed, and it happened against the consent. The court confirmed, court concluded that this is due to the rape has happened and there was no consent because of these injuries. So it's very, even just a small abrasion can serve justice in courts. So this is the hymenal tear of that girl. You can see a fresh hymenal tear at 6 o'clock position. And you all know this is a bite mark. You may say this is a simple injury, non-grievous, and you leave send the patient home after treatment. But when it comes to courts, the defense counsel will ask, doctor, did you identify the assailant through this bite mark? If you do not do dental referral, we cannot identify the assailant through this bite mark. That will collapse the whole case. The one question from the defense counsel can collapse the whole case, because you have to identify the assailant before punishing that person. So it's the first step. If that collapses, the whole case collapses, and the judge has to dismiss the case. The importance of injury description, collection of trace evidence, and maintain the chain of custody. You see a contusion closer to right knee. And if you say this contusion is somewhere around 39 centimeters above the heel level, that will help the courts to make the opinion, or the law enforcement authorities to make the opinion that this was caused by a car. So this is a primary impact injury. If you tell that length, that will help the courts to, or the law enforcement authorities to identify the vehicle. And also, if you find green paint flakes on this leg, you may collect it, preserve it, and hand it over to nurse or whatever the hospital authorities or the police. Get a signature from that person that you handed over those trace evidence. And that person who take it over from you has to give it to police officer and has to get the signature of the police officer. So that is called chain of custody. If you do not maintain the chain of custody, that also collapses the case. The drunkenness. When such a patient is admitted to private sector, he may have committed the offense of drunken driving. Therefore, it's your duty to assess the drunkenness. Under the motor traffic law, you have to record the opinion of under influence to make him liable for the offense. If you miss it, you miss the justice. And also causing annoyance, misbehavior in public, damage to public property after consumption of alcohol will aggravate the punishment. For these offenses I have highlighted in yellow, if you record a smell, so that will enhance the punishment. The section 174 of the penal law of the Sri Lanka, omission to give notice or information to a public servant by a person legally bound to give notice or information is an offense. The concept is we are servants of the king. We are bound to serve the king. If somebody damage another citizen, that is a damage to the king. Therefore, king has to prosecute against the alleged assailant. So that is a concept. Therefore, if you damage another person, you harm the state. Therefore, all the citizens are bound to inform it to the law enforcement authorities, including the doctor. So when you come across such a patient in private sector, you are bound to inform to police under section 174 of the Penal Code of Sri Lanka. The issuance of medical certificates to courts. You have to mention the time, date, the diagnosis, nature of the illness. You should not backdate the medicals to courts, and the period of unfit, and when he can participate for the case should be mentioned in your medical report. You have to maintain and secure the findings. The interesting thing is the patient can twist you. He may request kind of a surgery, which is a routine surgery. Say on 26th of March, he may request, doctor, I want to get done, I want to remove a lump. So please do it on 26th of March. You do it. Retrospectively, the patient comes to you and asks for a medical to courts because today is the date of trial. So then you have to mention this is a routine surgery. So identification of certain patterns may not have legal implications, but you may do certain referrals like these are injuries caused by these are self-inflicted injuries or caused by a friendly hand. So you may do psychiatric referral. A patient with abraded contusion on the neck. It looks like hanging. So this is a case of attempted hanging. Actually speaking, this is autoerotic asphyxia. He has a mechanism. He hangs himself. He compresses the neck. He has a mechanism. He induces hypoxia and he gets sexual pleasure. And then when he comes to the threshold, he loosens the neck grip. And then again, he goes into he induces hypoxia and get the sexual pleasure. It's called autoerotic asphyxia. It's very dangerous. If you exceed the threshold level, you can die. So these type of people need psychiatric referral. You may describe this as kind of regular or irregular, maybe circular kind of burns. But if you say repeated circular type of burns on the skin, that will help the law enforcement authorities to identify the weapon. If you identify this wound, this is a jewel burn caused by electrocution. If you identify and correctly document it, that will be useful for you to send a report in to courts in future for workman compensation cases. Privation or impairment of sight of the eye, privation or impairment of the hearing. If you come across these instances, privation of any member or joint, because of the trauma, the patient loses the joint. So permanent disfiguration, a laceration on the face, fracture, dislocation or subluxation of a bone or a tooth, and bodily pain for kind of over 20 days, or he is unable to follow his ordinary pursuits for 20 days. And as a surgeon, you open into chest cavity, abdominal cavity, and cranial cavity. You think that there is indication, but there is nothing inside. But you have already opened. That will make the injury grievous. So these instances give a big punishment. Therefore, you have a legal duty to inform it. A typical wife battery case, you can see a laceration on the eyebrow, and this actually makes the wound grievous. Also, when you come across such a patient, please give some clue about the weapon. If it is shot, stab, cut injury, any instrument likely to cause death, fire, heated substance, poison, a corrosive substance, explosives, animal, will aggravate the punishment of the alleged assailant. So if you give some opinion about this, about the weapon, that will be very, very useful in courts to formulate the punishment. For example, this is a dog bite. If you correctly recognize this as a dog bite and inform it to police, the owner of the dog will be given punishment for causing grievous hurt. And maybe a simple cut injury, but caused by a dangerous weapon. So the punishment is aggravated. So you can see the punishment for simple hurt causing abrasion and contusion is the judge can give a punishment up to 1 year, and causing grievous hurt, judge can give a punishment for 7 years. If the simple hurt has been caused by dangerous weapon, which I have mentioned in the previous slide, the punishment is 3 years. If the grievous hurt has been done by a dangerous weapon, which I have listed in my previous slide, the punishment is extended up to 10 years. So that's important. You may give some clue to the weapon. Issuance of cause of death and ordering inquest. Recently, a road traffic accident case treated in ICU. The patient died. The doctor gave the cause of death and the body was taken to home, and it's in a coffin now with all funeral arrangements. And this was informed to police, and police informed the magistrate. The magistrate is now about to make a statement, get a statement from the doctor. So doctor called me. So then I arranged with the police to take back the dead body to TH Peradeniya for autopsy and settle the matter. When you see a trauma case, even a kind of simple trauma, do not give the cause of death in private sector. Instead, request an inquest. And the importance of documentation and confidentiality. Proper documentation is a must, because you may called as an expert witness in future. So recently, I gave evidence in Ampara High Courts for an incident which happened in 2005. So this is almost 17 years. So you may be called upon by the court in future to give evidence on your trauma patient, because the patient has not been seen by a judicial medical officer. Therefore, proper documentation will save you. It's very important. So after 10, 15 years, you can peruse the document and give evidence in courts. And in accordance with the Right to Information Act in Sri Lanka, you have to maintain this, the confidentiality of the patient's detail. Do not give it to the third party without the consent of the patient. If you are to reveal it to insurance company or any other third party, get the written consent from the patient. Otherwise, it's an offense. And also tell your institution or the hospital to preserve all the documents up to 12 years. That is a statutory requirement. And at last, if you ignore the law, that's ignorantia juris non excusat. If you ignore the law, the gallows is closer to you. Thank you.
Thank you very much. That was very enlightening, very timely lecture. And also, I wish we had more junior doctors here who could have listened to you. Nothing more can be mentioned more than the documentation, which is very much lacking. If you don't write it down, you have not done it. And thank you very much, Professor Chandrasekhar Kodikara. And we wish you all the best. And we would like to hear from you more often in Canada Society of Medicine. Thank you.
Next speaker is going to be Dr. Manjula Herath. He is going to speak to us on erectile dysfunction. He's MBBS MS. He has worked as a consultant urologist in Badulla, King's Hospital, King's College Hospital, UK, and in Kandy. Currently, is working as a consultant urologist in Kandy. He will enlighten us on erectile dysfunction.
Morning, everybody. Thank you very much for your kind introduction. Actually, this is Yeah, this is a partly undertreated area in Sri Lanka because due to various reasons. We'll go ahead and then see what we can offer for this cohort of patients actually suffering due to this condition. So what is normal erection? Is a neurovascular phenomenon under hormonal control, and it is a physiological event for natural reproduction. So when you talk about erectile dysfunction, it's a not normal function. That means actually it's over erection like priapism and under erection like no erection. Both should come into erectile dysfunction. But for the purpose of discussion, it's mainly described about persistent inability to attain or maintain erection sufficient to permit satisfactory intercourse or sexual performance. So anatomically, we should know about something about the penis. It has a tough covering of both corpora. There's a tough cover, and it contains spongy venous sinusoid and blood supply from the pudendal artery, and venous drainage goes back to the prostatic venous plexus. So this tough covering is important because when the penis gets rigid, the blood accumulates in the corpora, and when it expands, the venous drainage gets restricted and cause rigid structure. So it is under control of higher center, and sensory input comes from various ways. It could be visual, tactile, even emotion. And there's a parasympathetic control produce tumescence and detumescence by sympathetic control. And somatic nerves help to get the sensory input. And endothelial cell function is the most important considering the current management of erectile dysfunction. It's a cyclic GMP-mediated nitric oxide production in the endothelial cells, which call smooth muscle relaxation in the corpora, cause increased blood flow to corpora. And normal phase of erection, first person has to have desire, and that causes arousal, or which is under high center control, and then rigidity, followed by orgasm, ejaculation, and return to normal flaccid state. So is it a disease? Erectile dysfunction is not a disease, it is a symptom of many diseases like atherosclerosis, various neuropathies, depression, right? So it is a symptoms. So it may be the early manifestation of coronary artery disease or peripheral vascular disease. So you should, when you treat the patient, you should understand bother of the patient, what patient is worrying. So sometimes some people comes that a degree of hardness or rigidity is not enough. And another person, that won't be a problem. So we have to go through what really patient want. And it may affect physical, psychological, and even the quality of life. So here I put two columns. One is cause, and other is risk factors. Cause is the one which is really causing the erectile dysfunction, and risk factors are the possible things that may aggravate the condition, especially smoking, excessive alcohol, metabolic syndrome, lack of exercise, stress, because those are the modifiable. Most of things we can modify by our lifestyle adjustment. And the causes, of course, commonly atherosclerosis of the pudendal vessels, that is early manifestation of atherosclerosis before the cardiac manifestation, or it could be a traumatic event like penile fracture or pelvic trauma, or venous leak, it is something congenital. So it could be an endocrine condition like hypogonadism, primary or secondary, prolactinemia, and hyperthyroidism or hypothyroidism. It could be a neural in origin like CVA, Parkinsonism, trauma, various neuropathies secondary to diabetes and CRF, etc. And lastly, I want to mention that loss of sensory input due to aging. That is one cause of erectile dysfunction in aging population. Currently, more and more radical prostatectomy is done for prostatic malignancies. And here the neurovascular bundle is very close to the, which is involving the maintain normal erection is very close to the prostatic capsule. So if you don't preserve it, or if you can't preserve it, there's a high risk of getting erectile dysfunction. At the same time, during the surgery also, there's a high chance of contusion and early erectile dysfunction. And I'm not going to describe about drugs, but there are antihypertensive drugs, antipsychotic drugs, and more. And we use this, especially the patient with prostate cancer, anti-androgen, LHRH analog, and 5-alpha reductase inhibitors, etc. Those things can cause erectile dysfunction. And this is a bit of busy slide. I just explained a bit because this is a psychiatric subject. It's very difficult to understand most of the time, right? Just to explain that the psychotic erectile dysfunction, it could be generalized condition like primary lack of sexual arousability or age-related decline of sexual arousability. That's a generalized unresponsiveness. And generalized inhibition like chronic disorder of sexual intimacy. I mean, these patients comes as a chronic sort of erectile dysfunction. If you identify those patients in at least to some extent, then you can refer to a relevant person to attend. Other thing is situational. Sometimes it may be partner related, or maybe related to the specific form of sexual relationship. And sometimes it may be high central inhibition owing to partner conflict or threat. So those things you can identify by using just simple consultation, what sort of things going on with this person. Or it may be sometime performance related. Sometimes first honeymoon day, difficult penetration, maybe due to female partner vaginismus or something. Then the person is attribute that I have a problem with my penis. I can't maintain my erection. So it goes as a vicious cycle, and ultimately patient will end up in erectile dysfunction. So the proper counseling and explanation at this stage is very valuable. And it could be due to various psychological depression and various psychiatric disorders. The most important thing is barrier between patient and doctor. Because we are doing busy clinics, and even in the private sector, there is not enough time to discuss the case. The patient thinks that doctor should ask my question. He's giving various ad hoc things, believing that doctor will come to the point. And doctor will think that, oh, it's his duty to tell his problem. So the problem exactly won't come to you. When patient discuss about something very unusual thing, you have to straight away ask whether you have such problem. Otherwise, the problem won't come to you. It is important to get a good sexual history, the current relationship, previous relationship, the patient's sexual orientation, and especially the history of partners, sexual history of the partner, vaginismus, and sometimes maybe vaginal anomalies, etc. And you have to ask about the morning erection and rigidity and duration, which I'll explain later why I'm asking, and the onset of the disease and progression, degree of rigidity and duration, and problem with arousal, orgasm, and ejaculation. And because these are only symptoms, so it's very difficult to predict the gravity of the disease. So because of that various scoring system, like International Index of Erectile Functions, they have put various markings, and to attribute, then we can, like low urinary tract symptom assessment, we can give a score for the particular person, and then we can identify the gravity of the disease. And at the same time, you have to get a proper medical history for the possible causative, the possible causes like diabetes, coronary heart disease, and drug history. Symptoms of hypogonadism and hypo or hyperthyroidism is very important. And psychosocial history, depression or other illnesses, onset and duration, precipitating event, sexual orientation, unpleasant experience, because that may provoke acute erectile dysfunction, and medication. This is a table to show, because when the patient comes asking these simple questions, you can identify most likely pathology in this patient, whether it is psychotic or organic. So psychotic erectile dysfunctions is very short duration, maybe a few days. He had good erection few days back, now comes with total erectile dysfunction. And it's complete loss of erection and situational dysfunction. And they are early morning erection is preserved. Unlike in organic dysfunction, it's gradual onset and gradually progressing. And it's a global dysfunction, and their early morning erection is no more there. That is very important. The examination important you need to know about body habitus, because metabolic syndrome is one causative factor for one risk factor for the erectile dysfunction. Cardiovascular and neurological focus examination is important. Look for the secondary sexual characteristic. Look for the testes, whether there's any evidence of hypogonadism. Especially look for the penile abnormalities like micropenis, Peyronie's disease, hypospadiasis, etc., which may be the causative agent for erectile dysfunction. We don't do many investigations, but we are mainly look for diabetes and hypercholesteremia. And if you are dealing with all patients, we do serum testosterone level, because aging, hypogonadism due to aging. And some patients we do the prolactin, LH and FTSH. Special tests we don't do unless we are going for a surgical intervention or medical legal reason for documentation. This is a patient who had a congenital sort of venous leak, where we do the cavernosogram and see where the leaking vessels, and it's just, if you can identify ligate, that is the treatment for that. Maybe complex sometime. And the most of time, the erectile dysfunction, as I mentioned, it's a symptom like a fever, body ache. It is a symptom of a disease. So except psychogenic or post-traumatic or hormonal causes, all other times what we do, we treat his symptoms to get his erection, not the disease. The aim is to achieve sexual relationship and not only rigid erection. Treatment strategy depend on efficacy, safety for the particular patient, which I'll discuss later, and invasiveness, cost and availability, and patient preference. First, we have to address relevant contributory factors like obesity, diabetes, all those things you have to address. At the same time, most of time, it is not a single person treatment. Depend on the underlying reason, we have to involve the other parties. Importantly, we need to detect early, because if we detect late, it's difficult to treat, as I mentioned earlier, because once it's become a vicious cycle, when the psychological component is more predominant, it's very difficult to motivate patient. And it's a goal-directed management, including patient, his partner, etc. And privacy should be maintained, and there should be enough time to discuss the issue. And we need to periodically reassess, and we have to follow up this patient. Then this is actually important, because when patient comes, we have to look for, especially elderly people, how risk of having sexual relationship for that particular person. If the cardiologically patient is very high risk, don't treat erectile dysfunction at that stage. First do the cardiac intervention first, and then go for the erectile dysfunction management, because he is having a high risk of myocardial infarction during sexual intercourse if the patient is high risk. When you manage, you have to identify the most predominant cause, but you have to treat all the causes simultaneously. And counseling and lifestyle modification is most important thing. Spend enough time to talk patient and partner, understand their expectation, discuss about misconcept especially, and regular exercise, mental relaxation, and treat modifiable risk factors like diabetes and smoking, etc. And psychosexual therapy is, I mean, bit of something away. I mean, it's not what we really do, but you can give some sexual education and I mean, discussion and motivation, all these things help you. But sometimes you have to get a psychiatrist involved in this part. The hormonal causes you have to identify and treat because those are reversible causes. And actually the revolution of erectile dysfunction management comes after this PDA5 inhibitors development. This was actually their advertisement in 1998 when they developed Viagra. Actually, the Viagra they developed not for the erectile dysfunction. They developed that for coronary artery disease. When we treat those patients, they found that the patients get erection. Then only the turning point comes and they start treating patient with 5-phosphodiesterase inhibitors. So we have sildenafil, tadalafil in Sri Lanka, but others are not available in Sri Lanka. Other medication now not in practice because the wide availability and safety and efficacy of these PD5 inhibitors. It is mainly it is not an initiator because when patient take this PD5 inhibitors, he has to have a stimulation. Just taking tablet won't cause erection. That you have to tell to the patient. And it involved with nitric oxide production with cyclic EMP pathway. And efficacy safety of all these reductase inhibitors, sorry, PD5 inhibitors are similar. And tadalafil has a long-lasting effect, and there's no effect with diet. And there's no increase of myocardial infarction rate. And contraindication, especially nitrate, there is no antidote. And alpha blockers are contraindicated except tamsulosin because we can give tamsulosin with tadalafil or sildenafil, and non-allergy. On-demand versus regular treatment because there's a bit of some people don't like that before relationship go and have Viagra 1 or 2 hours before because it's make bit artificial and it's make some sort of programmed sexual relationship than natural relationship. So because of that, now they're trying to develop this regular dose of tadalafil, low dose, daily therapy, and it is also used for low urinary tract symptom management. So patient come with both condition, we can combine. And non-responders, we can change the drug and see, right? Especially when in non-responders, you have to look for whether they are taking correct dose, correct timing, relationship with meal, etc. And now, because of post-radical prostatectomy patients, now they use regular therapy to penile rehabilitation to preserve the erectile dysfunction. The second line therapy is this alprostadil pellets you can put into urethra and absorb through the urethra. And ESW, not the one we use for stones, the small machines that promote the hemodynamics of the corpora. It's under research level, but not as a recommendation, but you can use it. The vacuum device where we fix this, I mean, this is a stepwise management, what I'm telling. Start from oral therapy and then go this pellet and then vacuum device. This is an non-invasive method. You vacuum, make the engorgement of the penis, and then you put a rubber band and maintain erection, get the relationship. But the problem is, it's not we can't keep the penis straight because beyond the proximal to rubber band, it is flaccid. And during ejaculation, you have to remove the band. and injectable device now available. And it's like an insulin pen patient can keep in his pocket, efficacy about 70%. And there are some situations it can cause priapism. Then surgical options, yes, definitive treatment can offer only for small number of selected patients with recanalization of the arterial system. And venous leak, we can go and ligate the particular vein if possible, but those are not commonly practicing because they are not common as well as sometimes difficult. The mainstay of treatment is surgery, is prosthesis. You have to mention that patient, this is an irreversible step because you are going to tunnel the corpora. See, he can't go back for any other treatment after that. So you have to counsel both patient and partner. And there are various processes they have developed by AMS, semi-rigid rods, then 2-piece and 3-piece implementable device, which I'll explain later. And first one is a semi-rigid rod where we put into the corpora, tunnel the both corpora and put the rigid rod, and which has a twistable hinge. When you want to bend, you can bend it down. And if you want to have a relationship, you can straighten it up. Then there's a 2-piece one is the second one where there's a pump and the reservoir at the scrotum. And when you open the pump, all the water is going into these rods in the penis, and it causes erection. And 3-piece one is more natural, and where the reservoir is placed in a different place. This is a 3-piece device. These 2 rods go into the corpora, and this is the switch in the testis, the scrotum, and this is the reservoir. This is the malleable one, which I mentioned earlier. So how do you do? We make a spinoscrotal junction incision. We dilate the corpora, which means that we are destroying all the spongy tissues, and put the device and connect it and get the erection. So you have to decide length and etc. before you do the surgery. So take home message is a common problem in society. Limited presentation on mainly due to lack of awareness and social stigmata, has a major impact to the society and may lead to family disruption. Improve awareness, identification, and proper direction simply settle the most of cases. And this is the wording given by Leonardo da Vinci. The penis does not obey the order of its master, who tries to erect or shrink it at will. Instead, the penis erect freely while its master is asleep. The penis must be said to have its own mind by any stretch of the imagination. Thank you very much.
Thanks, Dr. Herath. I think you covered all the aspects of the topic very well. And just to mention, you forgot to mention about the incidence. It's about 10 to 15%, even at the age of 20, 30. So, and it goes up to about 80% by the age of 80. So it's a very common disease. Unfortunately, we don't have much investigations here, apart from doing hormonal studies. And penile Doppler is something we are missing here. Where it can
sir, those things actually we do for, especially with, selected young patients as well as patients who are going for surgical intervention because of legal purposes and things. Because of the time issues, I have dropped some areas because it's difficult to cover in 20 minutes. It's a huge area. Because of that, I removed some part.
Just passing by comment.
Yeah.
Thanks. Thank you very much.
Okay, so thank you.
Thank you, Manjula. They were silent sufferers. And which I didn't like was most of the elder generation didn't like you telling age-related sexual inability. The word didn't excite us very much. Nisanka is laughing. Yeah, okay. And I have this honor of introducing Dr. Nisanka Jayawardena, next speaker, who is a giant. He's a major player in the surgery who is going to talk about minor surgical procedures. I didn't know, Nisanka, why did you choose that? Dr. Nisanka Jayawardena is a consultant general surgeon, specially interested in breast surgery, a giant in breast surgery in this part of the country, this part of the world, and has chosen this topic. Thank you very much. And welcome home. He's not a player in Colombo. He's a Kandy boy. And with his all these heavy workload in the college and all the activities in the ministry, without him, the surgical fraternity can't work. And let me formally thank you for all the work that you do in the NMRA, and you have enough problem there with the National Medicine Regulatory Authority, in the Board of Study. He's a very important player, board member in the specialty board member in the Association of General Surgeons, and he's an examiner in all the exams under the country, under the sun, I would say, and MRCS Edinburgh at MD Surgery and MD Otolaryngology, and he's a past president of the College of Surgeons of Sri Lanka. Thank you very much to have come. When you were getting late, I was a little worried, but you know, last night those would have helped you a little bit. Anyway, with that note, let me ask Dr. Nisanka Jayawardena to give this talk on minor surgical procedures in general practice. Thank you.
Thank you very much, Dr. Nias. Good morning, everybody. In fact, the too kind introduction probably. And more you know, said about various things which I also didn't know, I got more worried because it will be very difficult to match the expectations you had now given them. Right, okay. So now today I was happy to, when I discussed with Vajra, I was happy that I got this topic because people, I mean, surgeons in general, surgeons in practice in this country, see so many mishaps and so many accidents which occur because of unpreparedness and because of lack of knowledge in the general practitioners. On the other hand, the people in the general practice should be should give hand the general surgeons and the surgeons in the country to maintain the quality of service, because the patients trust the primary physician most. And it is very important that they understand what is their place in the service of surgery to the patients, and how to do it properly, not causing any problems, and when to refer, because they can relieve government practice, government hospitals very much, especially these chronic wounds and various other small surgeries. If the general practitioners do it well, they can relieve a lot of health burden in the country, and patients also will be happy. So I was happy to get this topic. Okay. So this is a joke. The general practitioners, he says, our hospital has the every best technology. I'll be using GPS to locate your appendix. That is because now, actually, we don't expect the GP to have all the facilities, but I have to stress, if you're embarking on any type of surgery using a local anesthetic, you should have at least the minimum facilities to perform it, because otherwise the patient will even rarely has end up in death. So what are the prerequisites in a general practice? So good lighting and reasonably maneuverably table, because the patient has to lie on a table. You can't do local anesthetic and you can't do even give a local anesthetic to the patient who is seated, because by any chance, if he drops the blood pressure and he'll be fainting and he might have brain damage. So you have to have a good table. Surgeon has to be comfortable and patient has to be comfortable. And then chaperone or assistant, especially chaperone, because now all these things we have encountered in our practice, even if like we also do a little bit of GP's practice as surgeons, these minor lumps and bumps. So we also have encountered, we have seen the lignocaine going into causing bradycardia and patients going into problems. And also in that situation, if you don't have an assistant or a chaperone, you are gloved up and you can't do anything. And at least there should be somebody to send a message. So, so you must always have a chaperone or at least a trained nurse. I mean, within inverted commas, she doesn't have to have a degree, but he should be trained and she should have some sight into what you are doing. Then basic equipment to monitor at least a pulse oximeter. And this, I think with COVID, we have got a lot of cheap pulse oximeters going around. And it's much better if you have a pulse oximeter, it's a warning. Because generally you are used to that. As surgeons, we are used to just unconsciously listening to that, sound. So that when the sound becomes more sparse and becomes the rate, then we are conscious of the rate. So it's much better. Otherwise, patient will go into a real bradycardia and without your knowledge, especially if you have toweled the face. Then basic equipment, emergency tray with non-expired medicines. Sometimes we get an emergency tray in the dispensary. That tray is like the chicken in one of these, this roasted chicken in one of these small hotels, like because they roasted it the day they opened the hotel. So I'm sorry about it. This tray, what I want to stress is you have to check whether the drugs, whatever necessary drugs like atropine, adrenaline, the drugs which is needed to resuscitate, are active and not expired. So periodical checking. Then the knowledge of local anesthetics. You can't give local anesthetics without a limit. So generally what we use, the commonly used local anesthetics are lidocaine or lignocaine with adrenaline or without adrenaline, and then marcaine or bupivacaine. Bupivacaine, of course, I would reserve it to a place where there is very proper resuscitation facilities are there, because bupivacaine causes, if becomes, it's a long-acting drug, long-acting than marcaine, the lignocaine. So it causes more drastic side effects. It becomes goes intravascular. So I think you have to be careful if you're giving marcaine. But on the other hand, it is long-acting. The action lasts for about 6 to 7 hours. So post-operative pain relief is better. But you have to have real facilities and know how to resuscitate if something happens. On the other hand, lignocaine is relatively harmless drug, but its action is only about 1 to 1.5 hours. But you have to know the dose, the toxic doses. And generally, as a rough guide, you can say for a grown-up man, it's about 10 ml of 2% lignocaine, but I wouldn't go to the limit. I would always take half and dilute with distilled water and shake the syringe. When you draw the distilled water and lignocaine, sometimes I have felt, in my experience, I'm sure Dr. Nias also would have felt, if you don't shake, first you get the lignocaine half and then you get the distilled water half, then you inject, and half the thing you inject is distilled water. And patients don't get anesthetized that well in certain areas. So I think it's better to shake once or twice once you mix. Then of course, facilities to sterilize instruments, linen, and bandages and dressings, because we don't want to have a line of infected patients, at least if they have a way of getting sterilized linen. But some people are working in hospitals, whether we like it or not, sometimes they can take a little bit of, I don't see that much of, offense in that, because they are also treating patients, but it is illegal. I don't want to, approve that, but somehow you must have a way of getting sterile products for your wound care. So always, as I said, always be prepared, right? Because otherwise, this man says to the other, I thought you were bringing paint. So because otherwise you might encounter problems, and it's not good for your name, it's not good for your economy, and it's not good for everybody. So I would advise you to insert a cannula before the procedure, and check for the patency. So I have come across all these things. Sometimes you allow one of the nurses, either nurses in the private sector, the nurses who have retired and re-employed. Sometimes with due credit to most of them, but rarely you get a nurse where you put in a cannula into the dorsum of the hand, and the edge, the point comes out through the skin again. Right? So, they have to be skilled. So sometimes the cannula is put, and then they say, sir, cannula. And then when you try to inject, cannula is out. So cannula is not useful if the thing is not inside the vein. So check the cannula. Always ask them whether they check the cannula. Put in a cannula, because once the patient is collapsed, bradycardia in a hurry, you are shivering, right? You are having tremors because you are dead scared, and then patient's veins have collapsed. So there are it's very difficult to put in a cannula, especially in the private sector. You're all alone, and rarely you call another physician or somebody is doing a channel practice and he has not put a cannula since the medical students' days. So put in a cannula, very important. That's why I'm taking such a long time for that. Then take a good history, including allergic reactions. Now, when you ask about the patients, have you had any local anesthesia? The patients say no. But then if you ask him or her, have you had a tooth extraction? They say yes. So that means they have had lignocaine, because for the tooth extractions, I have found in my personal experience, tooth extractions are the commonest incidents where our people are using lignocaine. So, so somehow see whether they have got exposed to the drug, and then always give adequate time for it to act before starting the procedure. Because if you give a best practice is, you give the anesthetic, go and wash your hands and glove up and come. Then it is acting. But if you glove up and come and then give the anesthetic, when you cut, the patient is shouting. And then you have to give vocal anesthesia instead of local anesthesia. Beware of infiltrating local anesthetic close to end arteries, because you might damage the end arteries, especially the fingers, toes, and of course the penis. And Manjula will have to be called. Then, if you infiltrate bupivacaine, make sure that you are, as I said, not intravascular. You have to always pull back, have this habit of pulling back when you give local anesthesia. So what are the categories of surgeries we get as general practitioners in GPs? So you get trauma, chronic wounds, and then superficial lumps and bumps. Traumatic wounds, commonly contaminated. You go for the delayed either primary, delayed primary or secondary suturing. Delayed primary is done in about 48 to, you just clean the wound well, ask the patient to go home, and then come back the next day, and then you suture the wound. The secondary suturing is you let the wound to heal and well granulated, and then suture it, whatever the period it is well granulated. So generally about 1 week's time. And of course, check for tendon injuries and cuts and lacerations, cuts and lacerations before suturing, because sometimes you suture especially the hands and the wrists and all, you suture the wound, patient goes home, and then patient finds it because of the pain, he doesn't move the finger. Patient also has missed the tendon injury, and you also have missed the tendon injury. And when the wound heals, patient comes and says, "Doctor, I can't move my finger." So you have missed the tendon injury, and then it's a bigger process. It's not as simple. If you detected the tendon injury, I'm not asking you to repair it, but you refer the patient. Then other thing is you may miss vascular and neural injuries unless you checked objectively. You have to check objectively vascular and neural injuries. And vascular injuries, you have to make sure about the formation of pseudoaneurysms also. Then always exclude underlying fractures, because with the injury, patient is not moving anyway. So if you not objectively check, clinically and radiologically, sometimes if you suspect, you will miss fractures. And all these things will lead to my friend, the professor who gave the lecture, medical legal issues. And especially these injuries may be related to either criminal activity or road traffic accidents. So you'll have to face the music. This is what happens when you primarily close a contaminated wound. So it has got infected. Now patient has to be treated with antibiotics and a longer period. Maybe the sutures will have to cut open and he will get a bad scar. If you come to the chronic wounds, proper atraumatic technique to preserve healthy granulation tissue is very important. Because you should not scrape or you should not, rub things. You should allow healthy granulation tissues to grow in a chronic wound. Now, general practitioners can play a major part in managing the chronic wounds. I'm sure they will hit the general surgeons and the vascular surgeons' economical the status, but I think it will be better for the patient if the general practitioners take over the managing the uncomplicated chronic wounds. They can, of course, think about the general surgeon or the vascular surgeon and refer the patient once in a while for an opinion so that they also can have some, money. But I think it's better, don't take me seriously. So, then then you do correctly acquired culture swabs and tissue culture-based antibiotic therapy as much as possible, because culture should be taken from a culture of the pathological or pathogens, and in a wound you get a lot of common cells, skin common cells. So culture, when you take, you have to wash the wound well with saline, maybe soap and water, then saline, clean it, and when you take the swab, get it from the middle of the wound, base of the wound, after washing very well. But if you go close to the skin, you will have common cells who are non-pathogenic. Then surgical desoughing sometimes can be done without anesthesia. Sometimes the chronic wounds which come to you, they're diabetic. Even if you amputate the toe, they don't feel. So you don't need infiltration of the anesthetic, because that also will affect the vascularity of the limb. So you can, at your practice, when the patient comes, you can't do the destuffing at once, but there may be certain areas with a pair of, if you are prepared to spend a little time, you clean it well, and then you take certain areas, you cut it out. You get, there are yellowish areas, slough, you remove with a small scissor, pointed scissor, and then a catch forceps. So in that way, with continuous dressing, you can get a reddish and well-granulated wound. Then you do not use irritants such as hydrogen peroxide, Savlon, and surgical spirits. I mean, I think you all know all things, and use salines. Normal saline and rotational antiseptics are cheap, but useful alternatives for more expensive wound dressings. Now, when the sales personnel come to you, they say, sir, this is made in Sweden. And then they try to bring in a wound type of wound dressing. Of course, they are effective, but you can get a similar or very, very close effect by just doing rotational antiseptics and saline dressings, proper antibiotic care, and proper debridement. So these are the key words in managing of the chronic wounds. Not the 5,000, 6,000, and 7,000. I'm not sure whether they will have somebody hit me when I go out. Dressings, in my experience, in our wards. Apart from, in suitable cases, of course, this is not for the general practitioners, you can have negative pressure wound therapy, which is quite efficient. And there are silver dressings, there are hydrogels. I mean, you can use all these things. And then chemical desloughers, you can use, but in the general practitioner, my opinion is, they may vary, but my opinion is you can do a lot with continuous, frequent desloughing and without any anesthesia, and then quite frequent washers with soap and water and saline dressings. Always send wound biopsies to exclude squamous cell carcinoma in chronic wounds, especially if it has occurred on a scar tissue. You all have heard about Marjolin's ulcer. Now, this might come as a wound, chronic wound, but these are the pitfalls you have to look for. Now, these are basal cell carcinomas. Typical site where they get exposed to sun. So you have to be aware of these malignant lesions, have them at the back of your mind when you are treating chronic wounds. This is a carcinoma breast. You might think it's a sebaceous cyst, and you might try to treat it, but it is not healing. So remember, always you must have these in your mind. Now, this is again a squamous cell carcinoma rising in a wound, a long-standing chronic ulcer, everted edges, what we learned during our pathology lessons in the 3rd or 4th year. You have to always check for draining lymph nodes, and definitely needs biopsy. This is a venous ulcer. So when the chronic wound comes in the gate area, you have to think of typical area, you have to think of venous ulcers, because these are not going to heal unless you treat the cause, so permanently. But you can, of course, use pressure dressings, cotton crepe, and you can get good results in venous ulcers. Then you do a Doppler study and then hand the patient over to somebody who is doing venous surgery for the further treatment. Chronic infections. Think of foreign bodies. Now, this person in the perineal infection, there are some suture lines and probably a gauze swab is inside, which is trying to come out. And then osteomyelitis. If the wound is not healing, think about the osteomyelitis. You have to decide. Otherwise, you have to just do an X-ray. So this is how a healing wound goes. First, the granulation tissue nicely seen, and then the skin edges grow towards to cover that. And then finally it has covered. So in the general practice, I think the lesions can be easily excised. Now this differs according to the experience, surgical experience the doctor has got. Doesn't have to be a surgeon, but there are doctors who has worked in as a general SHO, general surgery, and they have, or some other SHO job doing surgery, they have, they know the basics of excision. So I think sebaceous cyst, if you diagnose properly, I think you're fairly safe to excise the sebaceous cyst. You don't need biopsy also if it's a typical sebaceous cyst. Then small lipoma or dermoid cyst, again the internal angle or external angle dermoids, similar to sebaceous cyst or implantation dermoids. You decide with the site and also the history. Then pigmented patches, of course, if you are excising pigmented patches, you have to always keep the devil in mind, malignant melanoma. So pigmented patches, better to have better to assess well, and in a way it's better to refer to somebody also. If you are very sure it's not something malignant, keep at least 2 millimeter margin for the final, when you excise it, and then send for histology, definitely send for histology. And then if histology is positive, you have to do a further excision and then sentinel node and so many things. So you have to send the patient. So these are external angle dermoids. Sebaceous cyst, there will be a punctum. And as medical students, we are always looking at the punctum, but sometimes you can't see the punctum, especially in the scalp. But if you see a punctum, it's a sebaceous cyst. So these are lipomas. Sometimes you can have big lipomas. Big lipomas, it's a bit difficult to excise under local, because for the reason that you have to give a lot of local anesthesia. Sometimes you have to remember that you might exceed the toxic dose. Now this is another lump which has come as spinal TB, the Spots disease. And keloid is not for excision. You will have a better, bigger lump. Then finally, I will come to do's and don'ts, just to take home. Stick to Langer's line when making an incision. As much as possible, stick to Langer's lines. Beware when excising lumps over vessels. Example, radial artery at the wrist. You may be dealing with a pseudoaneurysm, and if you make an incision, the blood might hit the ceiling, and you will be at a, if you are alone, you might have a problem. Then, when there is doubt of the diagnosis, call a friend. You may be having friends in surgical training or surgeons or your supervisors. Surgical colleague can send a photograph via WhatsApp and then ask what it is, whether you can do it. Then always send for histology if the diagnosis is not sure. Always send for histology. Otherwise, patient is helpless, you are helpless if you put the specimen into the bin. Now, these are actually Langer's lines, but you have to go more extensively and study it. Then never operate on a resisting child. I have seen children losing toes by people trying to give local and destroying both end arteries and amputation. I have seen it. And then you might be able to persuade more cooperative and intelligent child for a local anesthesia. However, apply EMLA. tactic solution, mixture of local anesthesia, lidocaine and pilocaine. Cream for 45 minutes before infiltration, then you infiltrate. What I say is, I tell the child like a story. I will apply a magic cream, and then which magic cream will make you no pain, and then I will give the injection. Then I small prick, and the child knows that he is not in pain and very cooperative after that. Children are more sincere than adults, so they become very cooperative. Do not infiltrate infected skin. We see so many perianal abscesses, breast abscesses, pilonidal abscesses done under local anesthetic. I think we should refrain from doing it. But however, exception is you may drain an infected sebaceous cyst under local. Okay, thank you.
Thank you very much. What basics can do is very well enlightened by you. And back to basics, even for senior surgeons like us, Professor Galkatia, I think this very good lesson there. Thank you, Nisanka. Thank you to have come all the way from there, Colombo, and given this enlightening lecture. Before we wind up, we have formalities to do. Before that, this brings to the end of the Symposium 8. Then there's a plenary lecture, very interesting human evolution story in Hall A next to come. Please, after awarding ceremony, please go there. And please don't forget to visit our sponsors' stalls and visit them more often and be in association with them. Thank you very much. May I call upon Professor Galkatia?
Wait, Niaz, can I make a comment first?
To take your certificate.
Niaz, can you hear? Dr. Niaz, can you hear?
And the problem. And Professor Sarachandra. Yes, Professor Sarachandra Kodikare.
Dr. Niaz, can you hear me?
Then Dr. Nisanka Jayawardhan. That brings the Symposium 8 to an end. Please get to Hall A. Thank you very much.
Before that, ladies and gentlemen, I would like to ask you to remain seated just for a little while, because we need to thank the chairpersons of the sessions today. So in order to present the certificates for the chairpersons, Dr. M. Niaz and Dr. Sunil Samaravira, I would like to invite Dr. Vajira Jasingh to please come on stage. Thank you. So that concludes the 8th symposium, which was held under the theme of different dimensions of surgery. So as Dr. Niaz mentioned, I would like to invite you to kindly proceed to hall number A for the plenary lecture, which will be held in the first floor. And after conclusion of that, you may return to the hall B, which is this one, at 10:45. Thank you very much.
A kind reminder, we are hoping to start the next session, so please be seated. A kind reminder and invitation to all of you, please be seated for the 10th symposium scheduled for the third day of the KSM academic sessions 2022. Will be starting shortly. A very good morning to all of you. We are going to start the 10th symposium on the third day of the KSM annual academic sessions. This session or the symposium is focusing on rehabilitation in pediatrics. We have few eminent speakers joining us today. And to chair this session, let me now invite Dr. Shenal Talgahagoda and Dr. Pathum Disanayake onto the stage to chair the session.
Can we start? So welcome to this pediatric symposium titled Rehabilitation in Pediatrics, and this is in keeping with the KSM theme of non-communicable diseases. We have three very, very eminent speakers who are going to speak today. And each speaker will be talking to us for roughly 25 minutes. The entire symposium runs for 90 minutes. So at the end of the three lectures, we'll have a Q&A time of around 25 or around 15 minutes where you can pose your questions to our eminent panel.
So to introduce the first speaker is Professor Samanmali Sumunasena. She obtained her MBBS from University of Colombo. She has a MSc from University College London in pediatric disabilities, and she is currently professor in pediatric disabilities in University of California. Madam, can I invite you to the podium?
Also, I thank the organizers of the Candy Society of Medicine for inviting me to deliver this lecture, and highly appreciate identifying neurodevelopmental disorders as a timely topic to discuss and to disseminate knowledge about. I will be speaking. I have tried to condense the lecture as much as possible because I was informed that the screen will go black if I speak more than my time. So I will be talking for the next 20 minutes, hopefully, and I'll focus on what is neuroscience, the latest evidence. And since due to the time limitation, I will talk only about cerebral palsy and autism, but the same principles will go into the management of other neurodevelopmental disorders also. We'll try to touch a little bit on local practices that we are doing at the moment. So a neurodevelopmental disorder by definition is impairment in developmental domains. So I hope all of you know a little bit about developmental domains. So cognitive, motor, language, behavior, and activities of daily living are the domains, and these will get impaired due to some insult to the developing brain, and that will have an impact on the day-to-day functioning of children. However, these conditions are lifelong conditions. We can alter the course, but we can't cure it. So I start at the beginning, I say we can't cure it. I tell at the middle, we can't cure it. At the end also, I will stress on the fact that we can't cure neurodevelopmental disorders, but I will show you that it can work, right? So the most important factor that I want to bring in today is that early intervention is the key principle that we have to work to get that change in that lifelong course of these conditions. So which means in the first 1,000 days are identified as the golden period of child development, because that is the time that the neurodevelopment takes best. And you can see how the vision, hearing, vision, hearing, language, cognitive, and learning functions. Right, okay. Thank you. That's thank you so much. Yeah, thanks. So you can see that everything happens by 3 years, the maximum brain development, right? So this is something which was discovered in the late 1990s. And since then, people have been working really hard on child neurodevelopment, and they have found that the brain growth also maximizes by 3 years according to the weight of the brain. And the brain architecture, which is a very simple structure to begin with, by the age of 3 years is almost similar to the adult architecture, right? So the brain neurons, they form synapses, and these simple synapses will scaffold into developing into large synapses. So this happens through the large networks, happens through neural migration, synaptogenesis, myelination, and also if we don't want to learn something or if we are not exposed, there will be programmed cell death. So these are the processes that will initiate this scaffolding and development of the neural synapses at the microcellular level. So it has been found that the developmental potential in any neurodevelopmental condition is in a zone of modifiability, and it's a huge zone of modifiability which will also improve with time, right? And that is because of a process called neural plasticity. So this is a very important slide because every child, when they're born, they have something called experience expectant developmental process that takes place. So that means when a child is supposed to be smiling according to the according to the milestones, they will start smiling. When they're supposed to go on their force, they will start doing it. When they're supposed to stand, they will do it, right? So nobody has taught us to stand. Nobody has taught us to smile. Nobody has taught us to talk, right? So remember that happens through a natural expected mode of development, and that is called the blueprinting. Blueprinting, where the humans are blueprinted to develop, right? So that is the most important message that applies to all children. However, there's also something called experience dependence. So if children are stimulated more and they are given more chances to develop, they will be doing it in a more responsive manner, right? So that is called serve and return. Serve and return. You give them, they do it more. So that is called learning. So learning and development are in a continuum, and that is what is resulting in neural plasticity. So this is the theory behind everything that I'm going to talk about today. So look at this baby. So he's trying to crawl. He can't crawl. Then what we can do is we can put, so this is a child with a neurodevelopmental insult. So we can put a rolled towel, and he's still trying to do things, but he will do things better if you place something in front of him and encourage him to do. So that is experience dependent learning. So again, this kid can't walk alone. So somebody is supporting to do that. So this is the pathway that we are going to focus on when we are talking about early intervention, right? So let me just give a few examples with regard to cerebral palsy and autism with regard to this, right? So first step is identifying the risk, at-risk infant. When should we do that, right? So in theory, all children should be identified by 6 months. So 0 to 6 months is a very crucial time period where the doctors should be very alert, and we have to pick up, in my books, I think we should pick up everybody by 6 months. But globally, it doesn't happen. Even in the USA, autism is still diagnosed at 4 years, the majority. If you can't do it by 6 months, at least by 12 months, do it. But on principle, if you can't do it by 18 months, you're actually going to lose these kids. So see, neurodevelopmental pediatrics is not an easy subject. It's a very demanding subject. It needs a lot of skills to identify these children. And then how are we going to identify? Do you think we can just pick up any kid? No, we can't. There are evidence-based guidelines to do this. And I need to inform you at this moment, Sri Lanka, we have achieved a very successful milestone. We have developed all guidelines for neurodevelopmental disorders, cerebral palsy, autism, and other neurodevelopmental disorders, identification, management. and it will be in print and available by possibly May 2022. So that is one of the biggest achievements that we have done. So key to success in outcomes is based on these 5 factors: early detection, dedicated and competent teams looking after these children with updated evidence-based practice knowledge. Anybody and everybody can't manage these children. You need to be updated because the information is evolving on a daily basis. What we did last year is not what we do now, right? So this is a highly evolving area because people are still learning about this subject. And we have to give directed, targeted, specific intervention. So let me tell all of you, if you see a child who doesn't talk, please don't ask parents, send them to the preschool, the child will be fine, right? That is the worst message you can give them, because sending them to the preschool will not do anything for that child, because preschool teacher doesn't have the ability to intervene for this child, right? So please, if you all learn that message and go from here, I will be very happy. Committed and informed parents. So parents are the biggest partners in this game. They have to be our partners, right? And they have to be well informed about the condition, the outcomes, how we are going to act and what is going to happen. And then we need the collaborative services. This is something which we are still behind in Sri Lanka, but I think in the next 10 years, we'll be over that also. But remember, in the red, understand that we can not fix these children, but guide the parents to achieve the best. Also, if we do not practice the specific interventions, we are going to drastically fail the child and the family. So therefore, I am not going to talk to you about the specific interventions today because within this time I can't. But maybe someday we will learn those, and that is how we need to succeed. So cerebral palsy is the commonest physical disability in the world, accounting to about 2 to 3 per 1,000 live births, and the higher prevalence in LMICs. And look at this. In the developed world, majority of children with cerebral palsy do walk, right? But is that the outcome in our country? No, that is because we don't have those specific targeted interventions, right? So we have to target for this. We will do this in the next 10 years, right? So we have that outcome as well still. This is something which I got a picture about 15 years ago when I was at LRH. So this was a kid who came with severe dystonia and fractured cervical vertebrae. But this is a kid who is having dystonia, whom we have managed, and who is walking down the steps, going to school, using the laptop and learning in the classroom, right? And this is again a little girl whom I will show you this girl in a later one when she came for the first time. So she's also working in the classroom. We recently did a school visit for her. So this is where I'm bringing in some of the local practices. So these are the international guidelines which came out in 2017 by Novak et al. And they have identified some key factors. Don't worry about this picture. The important thing here is we need to identify the antenatal risk factors, right? So these are the most important antenatal risk factors that they have identified. Prematurity, all babies with a history of hypoxic ischemic encephalopathy, neonatal meningitis, seizures, and significant hypoglycemia. Of course, the list will be longer, but these are very specifically identified with CP from the evidence from the world, right? So general movement assessment is one of the key ways that we can identify these children. All children with cerebral palsy, at risk of cerebral palsy, can be confirmed to be at risk with a 98% reliability if we can practice GMA in the neonatal units before discharge, before the age of 3 months. So that is the point that we start interventions. We are having a island-wide course on GMS in May, and I would kindly request you all to register and participate. It is an online course. It's a very costly course. It costs about 2,500 euros, but we are doing it free for entire Sri Lanka. All consultants are invited to participate if you have time, but it's a 5-day course. We can identify them before 2 months with 2 features, or with even from 3 to 5 months with another 2 features, right? So I'm not going to give you details about it, but I'm just going to show you this video. Okay, the videos don't work with the laser pointer. 10 weeks. Mama Makata? Nitini. Nitini. Sakitya. T2. T2 of triplets. Just ignore the talking. Sorry, I could not switch off the audio. Just watch the baby. You can all see that the movements are highly restricted, right? So it's so important when we see babies in baby clinics to put them on a mat and observe them for their movements, right? So the movements are highly restricted. You can see that there are very minimal movements in the right side of the body, right? So in this baby, this type of movement is called cramp synchronizing movements, and it is definitively diagnostic of cerebral palsy even by the age of 2 months, right? And that's the point we need to start intervention. So all your babies born at neonatal units should go through this screening, right? To all babies admitted to NICU, sorry. If we can't detect them at that point, according to the guidelines, we can identify them by 9 months. If they cannot sit independently, if they cannot take weight through their lower limbs, feet, or if there's a hand asymmetry, right? So these are also definitive pointers, but of course there may be other conditions like other neuromuscular disorders. So we need to have a history and all those things coming together. So this is for the low-tech settings where they don't have GMS. There's another assessment called Hammersmith Infant Neurology Evaluation that also can be helpful to diagnose. So diagnosis is so important. That's why I spent quite a bit of time. So again, CP is a clinical diagnosis. There's no confirmatory investigations at all other than the MRI. But MRI is not available everywhere, and there's no urgency to jump and do an MRI if we have the evidence on the history. Then we can find a cause by doing all the other investigations, but that is to find the cause. Then we have to address the condition specific interventions, make parents aware, and we have to go for home-based management. There's no place for hospital admissions for management of neurodevelopmental disorders. There's no place, there's zero place for that unless they have a fit or they have some reaction to drugs or something like that. Because parents have to incorporate these activities into daily living, right? So cerebral palsy by definition is this. It has the old definition. This is from 2007. Where there is movement and posture disorder. It's a permanent disorder. It's non-progressive, but remember there's always associated other complications. So therefore, when we are managing CP, we have to address all these other complications as well. So just to tell you all, pathology of CP is not only the upper motor neuron lesion, it is also the lower motor neuron hyperactivity. So there are problems due to all these. So we need to address all these problems very early, and then we can prevent majority of the other things, but we can't prevent them 100%. So condition specific interventions, we need to start treatment with hypertonia lowering drugs even as young as few weeks, right? So for that kid with positive GMA, we have to start treatment. In our practice, we use benzoxazole and Syndopa. Baclofen is the evidence-based, which is available in the evidence-based guidelines. active motor learning opportunities by giving them a lot of opportunities, as I showed in that small pictures, how we give multidisciplinary management, right? Enriching the natural environment, giving a lot of stimuli in the environment to mobilize, to touch, to see, to hear, to talk, etc. Feeding and communication assessments, very important, because these children, if we don't address their communication early, they will not be able to talk. Look for other comorbidities like epilepsy, vision, hearing, etc. And lot of opportunities for play and interactions, right? So this is in our center. This is our old center where we were very crowded, and us working with the parents, showing them how to interact with the babies. And this is a group therapy session, right? So, and this is that little girl. I'm not sure whether the video will work. Okay. This is training pair. That is the girl who was there, who was walking. She's in school in year 1 now. So this is the dad and the mom playing with the child. And this is one of my trainees. We also have a physio and a OT in the background. So this is how we make parents partners, right? So we have to spend a lot of time. It can't happen like this in clinics, right? So let's come to autism. It's another major problem in the world now. In the US, they say it's 1 in 44. In Sri Lanka, we don't have figures since 2009 from Professor Hemali Pereira, which was 1 in 97. I'm sure it's 1 in 60 or something like that now. It's commoner in boys, but when it's in girls, it's more serious. It is also found that more children in low socioeconomic groups are presenting late, and therefore they are at a higher risk of intellectual impairment. And about 1/3 of kids will move into intellectual impairment simply because they are detected late, right? So it is mainly a problem with social communication and interaction, together with restricted repetitive behavior patterns. So the definition of autism also is from 2013 DSM-5, and symptoms must be present in early life, and there should be restriction of daily activities and should not be explained by other explanations. Now, this is again another magic. So people have found that you can detect autism as early as 0 to 6 months. Isn't it amazing, right? Why are we sitting on these kids till they are 4 years? So lot of new evidence. You can see 2 humps, but the first hump is identifiable. I'm just going to show you two little kids. This kiddie. Yeah, so this is a kid who had neonatal sepsis or something like that and came to our early intervention clinic. And this is a sibling of a kid with autism. She's looking at the fan. They're just both 4 months. Okay, no response at all, right? Look at the smile. Look at the smile, the beautiful smile with the physiotherapist who is wearing the mask and the face mask, the shield, and also a head scarf. And this is the kid smiling with the mom. So this is why autism is programmed. Autism is programmed. They are born with autism. So your facial muscles, your smiling mechanism is not there in place, right? If you don't detect at this age, they stop smiling and they just become self-stimulatory, and then you lose them. At 3 years, you have lost them, right? So this is an emergency to identify kids with autism because the numbers are rising so high, right? So joint attention is the ability to focus together to do an activity. This is what is lacking in them. And you can see joint attention developing as early as 2 to 6 months when you are giving attention. That is called responsive joint attention. And initiating joint attention is when a child initiates activities, right? So when we are talking about social communication and interaction, it's so important to understand babies do communicate from birth, and there's a lot of initiating, responsive joint attention in these pictures. And look at this guy, right? So this is social communication. We don't see this kind of engagement in children with autism. And look at this. This is copying, right? This is nonverbal behaviors, right? I haven't put videos because my videos get stuck most of the time. And this is interaction which builds relationships, right? So these kind of behaviors are not seen in children with autism. Problem in Sri Lanka is Sri Lankan parents don't know what is normal development. Their development literacy is very poor, right? So therefore they don't play with their kids. They think if the children can be like parrots, like repeating things, that is great, right? So they don't know to sit down and play with cars and toys with children. Culturally, we are not that. So we need to build that. I mean, we should never blame parents. We should teach them and empower them, right? So restricted repetitive behaviors are about repetitive speech, movement, and then having very rigid behaviors, very ritualistic, and having a lot of sensory behaviors, right? Just a little boy with autism who is lining up. He doesn't like his line being disturbed, right? So just to show you all the features. And this one, listen to his tone in the voice. He talks as if he has an accent, right?
Nicole. Nicole. Oh,
not responsive. So not responsive, just making utterances, not looking up to his name, right? So this is established autism, right? So this kid was around 2.5, 3 years when we saw, just to show you all the features. So in management, again, no definitive investigations, only play-based assessments. We use the DSM-5 and the ADOS both. ADOS only very rarely. That is the more research-based diagnostic criteria, making parents and partners, going in a multidisciplinary collaborative manner, and no medications, please, okay? So these are the ABP guidelines that has come out 2020, 2021. So that's what I said. Every year we get EBP guidelines. So intervention decision, because it's like a very multiple spectrum of conditions, child factors, evidence level of interventions that we are doing, family, how we are going to deliver the intervention, impact of the intervention on the family and the child, all these will come together into our intervention decision. So there's no one fit size for autism, nor for CP, nor for any other neurodevelopmental disorder. It has to be varying on so many factors. So that is why you need specialists to manage this, right? So there are primarily non-pharmacological, very rarely second line, there may be a tiny place for pharmacological intervention later on, but not before 4 years. Naturalistic developmental behavioral interventions are the most recommended. There can be a comprehensive program where within the day, how you talk to the child, even a simple thing like giving a glass of water, how you talk to the child, how you offer it to the child, all those things matter. And also there can be focused interventions like bringing in visual calendars and speech generating devices, etc. But what they say is the intervention should be at least 25 hours per week with one-on-one interaction between child and the parents. So just a few things about evidence to practice. Getting parents involved. Parent coaching is a core principle. Then using these video-based interventions where we look at the videos. I will show you an example. So this is our program for autism. So we have a very extensive program with one-on-one assessment and feedback, parent training, video monitoring, and then we also have group therapy and then school readiness, etc., etc., etc. It's a very life course approach, just to show you all how we train parents.
Ring a rang roses, pocket full of roses, ashes, ashes we all fall down.
So here the principle is child is responding to the parent, parent is actively interacting, and parent is having fun, no stress, and it's very natural, right? So our parents spend this time
all through the town.
so involving the other siblings also, so that they don't need to spend dedicated time on this child. This is a very mother from a very low economic background. So some principles are what we are practicing is daily routines, nothing else. Symbolic play, child-led activities. So child is doing it and mother is saying putada and the putada, right? And there's a lot of language coming in. There's modeling, there's repetition. And this language component is generally designed by our speech therapy team. But we also chip in because as consultants, we need to know what exactly is happening. Otherwise, we can't lead teams. This is a telehealth session where they send videos and we send them feedback, right? So we have video chats. I have 500 video chats with my parents, and I get about 200 videos per week, and I find time to respond to them, right? So don't give treatment. Don't prescribe, please, and no medications. Only the medications will be decided by a team after they are 4 years, right? When they are ready to go to school, we might need to give them something. No sensory interventions. Please go and tell everybody in Candy, no massaging of children with autism, no methylprednisolone, no stem cell transplantation. And that's it for autism, which I can tell within this tiny time. Remember, let's try to see whether we can identify them by 18 months. Bring in evidence-based practices. We'll have the guidelines out soon. Make parents responsible, home-based interventions. Remember, we don't want our children to survive. We don't want them to thrive. Thank you.
Thank you, Madam, for that very comprehensive and interesting lecture. I think a lot of those things were very new to us and hope we can adhere to your advice. Our next speaker is Dr. Channa De Silva. He's the consultant pediatric pulmonologist at Lady Ridgeway Hospital, Colombo. Channa obtained his MBBS from the University of Colombo with second-class honors and a distinction in pediatrics. And he was also awarded the Dr. Alaric Jasinger Memorial Gold Medal in Pediatrics. He obtained his MD in 2012 and had the distinction of coming first in the merit order in both the MD Part 1 and Part 2 examinations. He embarked on a career in pediatric pulmonology thereafter and was trained in this subject at the Royal Manchester Children's Hospital in the UK. And he was both certified as the first pediatric pulmonologist in Sri Lanka in 2016. Channa is the author of many publications in peer-reviewed journals and has obtained many awards for his publications. Over to you, Channa.
Good morning. Thank you very much, Dr. Senal, for that kind introduction. First, I would like to thank the organizers, KSM, for inviting me. And this is very interesting symposium. I think this might be the first time in Sri Lankan history, this type of focus on rehabilitation, different types of different aspects of rehabilitations. So it's very interesting, following a very interesting talk by Professor Samanmali Sumansena. Now I am mainly focused about the pulmonary rehabilitations. What are the things we can offer to a child with chronic respiratory problem? So straight away, if we go to the definition, so this is important. First thing is we don't have a separate definition for pediatric patients. So still we are using this American Thoracic Society and European Respiratory Society combined definition, which is mainly published in 2013. Recently also they have update, but even 2021 update also they are still using the same definition. So it's a comprehensive intervention based on a thorough patient assessment followed by patient tailored therapies. So it's very important, individual patient tailored therapies that include but are not limited to exercise training, education, and behavioral change designed to improve the physical as well as psychological. So psychological part is also important. Conditions of people with chronic respiratory diseases, and to promote the long-term adherence to health-enhancing behavior. It's a little detailed definitions, but it contains all the necessary informations which define the cause of pulmonary rehabilitation. So actually, to be honest, this definition, they mainly focus about adults, especially adults with chronic lung diseases like COPD. But still, there's no specific definition for children, but still we can work within this definition. Probably there won't be any definition for the children because this definition is covered. So we'll go through what are the important aspects of this pulmonary rehabilitation program, just to have an outline about the focusing main aspects. So what are the indications? Which children, the children with which kind of diseases need this rehabilitation related to this respiratory symptoms? It's mainly children with chronic diseases involving their respiratory system, mainly advanced chronic lung diseases. Mainly children with bronchiectasis. As you know, bronchiectasis is not a diagnosis. There are several causes, several etiologies which lead into bronchiectasis, maybe cystic fibrosis. As you know, we have many patients with cystic fibrosis even in Sri Lanka. As also, it's not a disease of West no longer. Primary cell dyskinesia, bronchiolitis obliterans, post-infectious changes, reflux, severe reflux, or primary immune deficiency. So even secondary immune deficiencies can cause. There is a wide spectrum of etiologies which can lead into significant bronchiectasis and lung damage. Even interstitial lung diseases is little bit rare in comparison to adult in children, and other restrictive lung diseases. Even pulmonary hypertension, there is a place of providing this pulmonary rehabilitation program, little tailored according to the underlying etiology. And especially neuromuscular conditions, Professor Samanmali very comprehensively mentioned about the need of motor development and psychological thing. And children with this type of neurological problems, they can have recurrent aspiration, respiratory problems. And these children also, there is a role for respiratory rehabilitation as well. And still we don't have this experience. Lung transplantation is a very limited experience in children, even in other developed countries because of lack of available donor lungs. But this is another important aspect, pre and post lung transplantation. Even asthma is, we know it's a chronic disease, but there are now evidence coming even in children. Pulmonary rehabilitation programs can improve the quality of life in children with asthma. And obviously, it's mainly currently being studied, being practiced in adults with COPD, this pulmonary rehabilitation program in a more advanced way. So what are the benefits of pulmonary rehabilitations? Obviously, first thing is symptomatic improvement, especially children with advanced diseases. They are having significant limitations of their activities of daily living. They are symptomatic in advanced diseases with significant lung damage, significant hypoxia. They are shortness of breath, having shortness of breath. They are having fatigue, especially if they are in later stages of terminal illnesses. They are having a lot of issues with carrying out the act, especially with physical activities. So symptomatic improvement is one of the main objective as well as the main benefits, and obviously increase their physical activities, exercise capacity, not only the physical things, all these interventions improve their ability or to cope these things, or they improve their the confidence, and finally it's improve their psychological health because of improved feeling well-being and decreased feeling depressed or anxiety. And other important thing is reduce exacerbations. As you all know, when there is underlying, I'll show some pictures later, bronchiectasis especially, they are more prone to develop recurrent respiratory tract infections, recurrent hospital admissions, persistent symptoms. With these programs, especially with this airway clearance, the reduce the exacerbation rates also reducing. That's also again important benefits. And other thing is, this is not only the physical part. So it's an integrated program which involving the patients, parents, as well as the healthcare workers, especially the multidisciplinary team. So when this organized program is going on, so they can have a very, very good understanding about the disease. So this education is a part of pulmonary rehabilitation process, especially long-term diseases, chronic diseases, disease without a cure. So finally, they realize the final outcome of this disease, but that is important, not in a negative way, in a positive way, to cope up with the disease, improve the quality of life, as well as the increase the life expectancy in children with this type of chronic lung diseases. Many of them are, like example, cystic fibrosis, life-limiting diseases. Even with very sophisticated developed countries, the life expectancy of cystic fibrosis is 40s, still 40s. So it's very rarely they survive beyond 50s. So there are these diseases significantly life-limiting, as well as they significantly reduce the quality of life of these affected children. And otherwise, or most importantly, when we are dealing with children, their physical activities, growth, all these things are important. If their respiratory system is affected, obviously, it significantly affects their rest of the growth as well. And finally, as I mentioned, so important thing is all these interventions finally lead into improve their quality of life, because some of these conditions are incurable. Some of these children might have this congenital disease, or maybe say pulmonary hypertension, very difficult to treat. Finally, they will succumb. But during this, sometimes it may be a short life to improve the quality of life of these children. Some of these unfortunate children with chronic diseases, which we don't have a cure at the moment. According to this ATS ERS 2021 update, they have identified 4 main components. The important thing is all these components are interrelated. I'm sure you are very familiar with this asthma management, the cycle of assessment, adjustment, and review. So this is also almost similar thing. First thing is, we have to have a very good assessment of the patients. I'll discuss a little bit details about these components. And then we have to make a proper program. It's very important according to the child's conditions, their socio-economic other aspect, as well as their final expectations. All these things are, and the available facilities, all these things are important to develop a pulmonary rehabilitation program. It should be an individualized program. Another thing is the method of delivery. It's important. And other countries now they are going to level the community level, especially giving these programs, home-based programs. But our setups, we are still restricted to the primary, or not actually the hospital. Hospital also, it's only available at the tertiary care hospitals at the moment. And then the quality assurance, review of this process continuously, because these are changing, evidence are changing, and we have to have a very good staff, which is one of the major obstacle in our setup, as well as equipment. Some of these interventions need sophisticated equipments, but even our setup, we are adapting to our available resources, as well as using whatever the local methods to improve the quality of life of children with these chronic lung diseases. So what are the things? It's a huge thing, assessment. It's if in a comprehensive assessment, there are many aspects we have to focus on these children. If we touch about the major important components, the pulmonary functions, the best available, the easily available one in our setup is the spirometry. For other countries, even is infants, there are infants pulmonary function tests are available. So to get some objective idea about their current level of or degree of functioning of their respiratory symptoms, their respiratory systems, and then the degree of their exercise tolerance, because these pulmonary rehabilitation programs are associated with the one component is exercise. This is very important to persons to identify what is the current degree of their impairment, where their exercise tolerance. 6-minute walk test. That's a very simple method to identify their exercise tolerance. So actually the objective assessment is the distance which these children can walk over 6 minutes. How this 6 minute, the magic number came is all these through studies, research with evidence. Initially 3 to 5 minutes short walk, and some studies they have gone up to about 10 minutes. So identify the 3 to 4 minutes would, or maybe up to 5 minutes would be a little shorter, might not be able to get a proper idea about the child exercise capacity. And it's going up to 10 minutes would be too long. And again, child might be getting exhausted and again might not give the proper idea. So finally, the currently understanding is a 6-minute walk. The child should walk in his or her normal phase without running for 6 minutes, and we have to get the distance with this child walk with 60 minutes within the 6-minute periods. If they are having significant problems in their respiratory systems, they develop dyspnea, fatigue, sometimes the saturation might drop, and even they might stop after walking for a few minutes, and their distance would be reduced. So the objective assessment is the distance, and as we can compare with the, there are some nomogram as well, but most important thing is child's individual performance. We can do this regularly, maybe 6 monthly or even 3 monthly interval to assess the progression of their respiratory status, especially their exercise tolerance. And inspiratory muscle strength and endurance. There are specific gadgets, equipments we can measure the muscle strength. And dyspnea assessment also, as you know, there are various scales are there, like Brock scale, modified scales. Nutritional status, one of the most important thing, any child with chronic diseases. So chronic lung disease is also very, very important conditions which reduce their nutrition. There are many causes. One thing is recurrent respiratory infections, recurrent hospital admissions, reduce their intake as well as increase expenditure, because these children, when they are later stages of disease, they are having significant dyspnea. So their expenditure is also very high. And have to review their long-term management. If they are in a long-term management up to now, before starting a proper pulmonary rehabilitation program, we have to assess what are the current management, whether this child is using this management properly, especially inhaler technique, airway clearance techniques, and some children might be on home oxygen, so oxygen delivery systems. All these things are important. So we are managing a child, not the respiratory system. So we have to have proper idea about the child's overall nutrition status, other comorbid conditions, and the psychological assessment. And in addition, their overall social background. All these things are important to have a tailor-made pulmonary rehabilitation program. Not only children, any patient. Age is not a barrier. So what are the things we can do in a major component of this pulmonary rehabilitation program? One thing is this exercise training. So exercise is one of the important key component which is lacking in our setup because of the lack of trained physiotherapists to do these things. And as clinicians, we are busy with children, so it's very difficult to engage in with exercise programs. But this is one of the important area, and there are some specific equipments which facilitates this, especially improve their inspiratory muscle strength and expiratory, so improve their total capacity or the strength of their respiratory system. So there are endurance training, resistance training, and we can focus about the upper extremities, lower extremities, and other important thing is airway clearance. So that is one of the important which is we are practicing in our setup, especially children with bronchiectasis. And obviously education is very important to give overall idea about the child's conditions, available therapeutic options, and the prognosis of the disease as well. So how do we deliver these programs. As I mentioned earlier, currently mainly we are providing these services in hospital with teaching them the like example, airway clearance. So they are continuing with that home, and in their clinic visits, we reassess and continue this assessment. So it's very important to have a proper organized program. Other thing is need a proper MDT team, multidisciplinary team involved in the different healthcare professionals, including the medical persons, nurses, physiotherapists, as well as psychological support and social support is also important in these patients, which is still not well developed in our setup. Another thing is the component is the quality assurance, the continued care and improving these care continuously. So the program should be documented with this with standard operation procedure, and we have to review this program regularly. And especially again, the multidisciplinary team is important, and the evidence, according to the available evidence, we can adjust this treatment to find out the most important or the most efficient program for these children to support, to improve their quality of life through these pulmonary rehabilitation programs. So I will just go through a little bit about this airway clearance techniques. This is one of the important part of this pulmonary rehabilitations, because many children, when we see these children with these chronic lung diseases, due to various etiologies, as I mentioned earlier, whatever that is underlying etiology, most of them are finally end up. Most of these diseases finally lead into a common pathway and finally end up with significant bronchiectasis. The issue is of bronchiectasis is once it is established, it starts a vicious cycle. With bronchiectasis, you know, with recurrent infections, and this infection leading to inflammatory process, involvement of lot of cytokines, lot of cells involvement, and these cells produce lot of proteases, is enzymes leading to tissue damage. Especially it's involved the destruction of the architecture of these bronchi, the airway, especially the skeleton of the airway. So this damage leading to the dilatation of these bronchi. When these bronchi are dilated, the mucus collected within these bronchi. But some diseases, as you know, like cystic fibrosis, the disease itself causes thick mucus. The impaction of these mucus within the bronchial lumen, obstruction, more accumulation of sputum, and more accumulation of organisms like primary celiac dyskinesia, same phenomenon. But any other disease, once this bronchiectasis process started, the vicious cycle become activated, even though there are no involvement of like cystic fibrosis or PCD like thing. Once the bronchiectasis is established, even in some other conditions, even in like bronchiolitis obliterans like conditions, even interstitial lung disease, finally leading to this mucus accumulation, and this mucus contain again a lot of cells. These cells produce cytokines, proteases, and again leading to infections. And because it's a very good culture media, more tissue damage, and this cycle will go on. So airway clearance is one of the important management or the part of this long-term management, especially this pulmonary rehabilitations, to break this cycle. It is essential to break this cycle to delay the progressions. Other important thing is once this bronchiectasis is established, obviously by definition, it's permanent dilatation, but in initial stage, because this definition is also now been little changed, initial stages, it might be reversible if we identify it early and start interventions early, appropriate antibiotics as well as the airway clearance. But once it's established, these changes are permanent. So because of that, only thing we can do is to prevent, or it's again, this prevention is also difficult. Only thing we can offer is to reduce or delay the progression. Usually it's going down. So why it is important to have this airway clearance? You can see, so some conditions, for example, cystic fibrosis itself have this very thick mucus. And once this lung damage happens, so the lung get sometimes the layers of mucus within the lungs. So all these changes can happen in advanced diseases. Even in children, we can see. Actually, the photograph I included in the first slide, that is a patient we are in follow-up at the moment, in follow-up in our clinic. So this type of lung damage happen in advanced disease. so thick mucus and significant lung damage. So we have to clear this mucus. So you can clearly see the accumulated mucus. So we have to clear this. Okay. So what are the things? I'm not going to details about the methods of airway clearance. There are independent methods. The person himself can do like breathing control techniques, postural drainage with the gravity assisted drainage of these areas. We can use several postures to drain the affected lobe, especially in localized disease. And we can use this, we can get the assistance of a therapist, a percussion techniques you are very familiar. There are various methods we can use. And then the dependent services, that means mainly with these devices. So these devices, there are two mechanisms. One thing is provided PEP, positive expiratory pressure. This positive expiratory pressure or giving some resistance to the expirations, improve the lung expansion, improve the collateral ventilation. That is important to push these, or it's the main objective, get some air column behind this mucus plug. So if we can get some air column behind this mucus plug with coughing and with the other techniques, we can push this mucus into the proximal airways. Once we push these mucus into the proximal airways, then child can cough it out, especially older children. There are various methods are there. They are calling this oscillating PEP devices. Oscillation is there. So these are the PEP devices, positive expiratory pressure devices are there. Various gadgets are there. And these oscillating PEP devices, this oscillatory wave transmitted to the lungs or through the airway, like the same way that we are tapping by a person or the physiotherapist. The same, this is internal tapping. And there are many devices, and sometimes there are West device. This is the external high frequency chest wall oscillation. Like this, there are various methods are there. But our setup, we don't have many children. We don't have these facilities. But same effects can be obtained through this bottle PEP. So we are using a bottle with a 10 centimeter water. The PEP is the positive expiratory pressure is 10 centimeter water, and this we are asking the child to blow through this water, and this bubbling create some oscillatory waves, and the effects are almost same. So these are two children in our setup. We are using this device, and agents are also there that facilitates this process, like hypertonic saline, dry powder mannitol is not available in our setup. DNases, it's very important, very effective things still which not available in our setup. NAC, N-acetylcysteine, even though we use, this is actually now completely out in most of the countries. They don't use because the results are very, very poor with NAC. And other thing is the prevention and management of respiratory infection. This is also important to prevent the progression. That is another part to break this cycle of infections, inflammation, and the bronchiectasis cycle. So we are using immunization, especially influenza, pneumococcal vaccines, and especially regular cope swabs or the sputum cultures to identify the flora, and then they develop, especially identify the infections early with the change of their sputum behavior, the color, the amount of sputums, before developing evidence of overt infections. It's very important to identify early and starting antibiotics, especially IV antibiotics, sufficient duration, at least 14 days of IV antibiotics. And so respiratory muscle training, I'm not going to details. This is a very different subject. So mainly improve the strength. So there are two aspects we expect. One thing is to increase the strength. Other thing is to improve the endurance of these muscles. The strength usually we achieve through with high intensity, short duration activities, and endurance improve with low intensity, low duration activities. So, and breathing exercise, very important, like this belly breathing, improve the diaphragmatic breathing, breathe through the nose and breathe out through the mouth, and mainly focusing about the increasing the expansion of the tummy. That means improve the diaphragmatic breathing. And pursed lip breathing is another technique which I usually very frequent, especially children with functional breathing disorder, especially dysfunctional breathing like conditions. Pursed lip breathing relax their muscles of respiratory things, and that's relieve their obstruction. Sometimes some children feel something stuck in their throat, sometimes they feel the breath is not enough. the important thing is sometimes these pulmonary rehabilitation programs are important not only for children with structural diseases, sometimes with this functional disorder, because these functional disorders also they are disabling significantly, especially children, they cannot go to schools, they feel breathlessness, but it's not the actual structural disease. Breathing techniques and respiratory muscle training. There are special gadgets to improve the breathing, especially breathing through these equipments which restrict the inspiratory flow. That is also giving some resistance to flow that improve the respiratory muscle strength. Another important thing is nutrition. So growth and nutrition is one of the important aspects, especially when we're dealing with children. So nutrition is one of the important aspects. So providing adequate nutrition. So Professor Heshan, within next few minutes, he will start his presentation about the nutrition. I just want to show, this is actual patient, one of our child with cystic fibrosis. With adequate nutrition, you can clearly see the dramatic improvement, dramatic weight gain with adjustment of their pancreatic enzyme supplementation. So in summary, pulmonary rehabilitation is an essential component in the long-term management of children with chronic lung diseases. Utility in children is very limited. It's a global thing. These programs mainly now focus on adult patients, but proper assessment, exercise, airway clearance, nutrition, psychological support, and quality assurance for successful program all are important key component in this rehabilitation programs. Although evidence is scanty in children, it's very, very important and beneficial item in the management of children with long-term respiratory diseases. Thank you very much.
So thank you, Channa. I think we have not given you enough time to cover this vast area on pulmonary rehabilitation, but well done on your presentation. The next topic is on nutritional rehabilitation. The speaker is no one new to this symposium, Professor Heshan Jaivir. He obtained his MBBS from University of Peradeniya. He is a board certified specialist in general pediatrics, currently serving the teaching hospital Peradeniya. And his areas of interest is childhood nutrition. He's a person who practices what he preach. So you can see that his nutrition status is also in good order. So Heshan, can you please come to the field?
Thank you, Patum, for those kind words of introduction. And let me first of all thank the Candy Society of Medicine for giving me this opportunity to talk about a very important aspect in relation to children. So within the next few minutes, I will be talking to you about nutritional rehabilitation in children. And this is a very vast area. So I will try to concentrate mostly on children who are less than 2 years. And we will not go into much detail, but I will be talking on the principles of management. So talking about nutrition, I don't think you can talk about nutrition rather than, talking about growth, because growth and nutrition, they go hand in hand. And people, whether it is doctors, parents, or anyone, for children, people talk about their growth. They wonder whether children are adequately nourished and so on, whether they are growing adequately. And therefore, growth becomes an indicator of well-being in children. And we also know in our day-to-day practice that poor growth, or someone say failure to thrive, or suboptimal growth is a fairly common entity. And it is not a diagnosis. It is basically a problem. And therefore, with a problem, you need to find out as to what the underlying reason is. So the underlying cause for the poor weight gain or growth is always an issue of insufficient usable nutrition. And to this cause, there may be many other underlying problems like medical disorders, psychosocial stressors that can contribute. So with that background, we need to identify who are the children who are faltering in growth if we are to do interventions. So therefore, it's important to find out how we will assess children. Now, all of you know that we do growth monitoring, and the growth monitoring is not only in terms of weight and length, but we also monitor their occipitofrontal circumference because it becomes an important predictor of brain development. Talking about nutrition, in addition to the weight monitoring, we can do weight for length and mid-upper arm circumferences, C-scores. Or if you like, you can take the absolute values of the mid-upper arm circumference, or you can talk about the average daily weight gain. So if you think about the Z-scores, you will realize that when we divide patients into mild, moderate, and severe malnutrition, the Z-scores for weight for length between 2 to 2.9 is considered as moderate malnutrition, and anything less than -3 standard Z-scores is considered as severe malnutrition. If you want to take the mid-upper arm circumference, a value of less than 125 will be taken as moderate malnutrition, and a value less than 120 millimeters will be taken as severe malnutrition. So what have we done in Sri Lanka? You all know that these were introduced maybe about a couple of years ago. And these are important things that all of us as practicing clinicians, doctors, whatever our grade is, that we need to utilize, because plotting a child on this will allow us to determine whether the patient is in the moderate acute malnutrition state, that is if they are within this yellow region, or whether they have got severe acute malnutrition if they are below the yellow region. So these are important things, and plea to you is to utilize these effectively in your day-to-day practice. So if you talk about the average weight gain, you will realize that the average weight gain varies with time. And this is very well depicted in the child health development record, where you will see that the babies gain weight fairly fast within the first 6 months, and then the curve tends to plateau off. So roughly a term baby within the first month should gain about 30 grams, and then it goes down to about 18 grams by the time they're about 4 to 6 months, and then it gradually goes down. So now, having known the ways to assess, I think it's important to know what are the conditions that could give rise to poor growth, because patients are going to come to you and you have to have the background knowledge to try and assess what may be going on. So if you look at the prenatal causes of poor growth, children can have growth retardation in utero for various reasons. There can be prenatal infections, and of course, there could be contributions from prematurity. When you take the period from birth to 6 months, majority of children will grow really well, and it's not a major problem. But we do find patients who have problems during this period. So if you do get a child who is having concerns of poor weight gain, then the issues to think about are whether there are any concerns in relation to breastfeeding. It might be maternal illness. Sometimes we have mothers who are quite old giving birth to children because of assisted pregnancy things. Sometimes there are multiples, twins, triplets, where the mother may not be able to sustain adequate nutrition for everyone. And of course, there can be illness. So we'll talk about illness in a short while. And beyond the 6-month period, between about 7 months to about 1 year, feeding problems are very, very significant and important, because that's the time complementary feeding has been commenced. And if you don't get the appropriate complementary feeding in, you will see that patients will not be gaining weight as they should. Of course, illness can set in at that time, or if illness was not diagnosed in the early stages, then illness can continue. Because of the introduction of complementary feeding, sometimes food allergies can set in, causing diarrhea and so on, and that can also have an effect on weight gain. Beyond the age of 1 year, sometimes children become picky eaters. They get distracted because parents sometimes create environments which are not conducive to feeding. And of course, acquired illness will play a part. Now, if you look at the pathophysiological mechanisms in relation to poor weight gain, then again, there are ways that you can divide these things. So inadequate nutrient intake can be a major factor, and that could be related to the diet. So it may be adequacy or inadequacy of diet. And when we talk about the diet, you talk about not only the quantity, but you talk about the quality of diet. Okay, so that is one problem. Sometimes there is lack of knowledge among parents, caregivers about what exactly to give. That results in food being offered to the child which is not of good quality. There could be problems in relation to swallowing and oromotor coordination, which will lead to an inadequate nutrition intake. Then, of course, you can have inadequate appetite and the inability to consume adequately. And this mostly happens because of illness. With illness, all of you know, appetites go down, so they will not want to eat. And then there are illnesses like underlying cardiac disorders where their work of breathing, or maybe chronic respiratory problems, where their work of breathing is increased and they are unable to eat because they are unable to suck from the mother because they find it difficult to coordinate the breathing and feeding. Then, of course, neurological mechanisms like maybe patients with cerebral palsy can have similar problems, and similarly with GI disorders. The next important thing is that there could be problems in absorption of nutrition, and there could be increased losses. And this obviously either happens because of malabsorption and in diarrhea. Not uncommon, but these need to be thought about. And then, as Channa very correctly said, there's increased energy requirements in some children who are sick. And we see this in patients who have got congenital heart disease, those who have got chronic respiratory illnesses, the patients whom we come across, maybe children with CF and so on, and various other chronic systemic illness. So with that background, I would like to now take you to a case scenario. This is a growth chart of a baby who was actually with us. And you see that when you see this growth chart, you will realize this baby was born with a reasonably good birth weight. And then you see that the patient has faltered, and then there is poor growth, and then subsequently there is catch-up growth. Okay. Now you would know that majority of babies, I said, within the first 6 months, they grow well. They grow well. We generally don't have problems. So what are the underlying possibilities? You know, we need to think about it, right? So if you see a baby who is not growing well in the early stages, you need to find out what is going on. So what possibilities are there? This could be maybe underlying congenital heart disease, heart failure, baby is unable to suck, so may not be getting sufficient milk, right? It could be a baby who's got a congenital laryngeal stridor, again, increased work of breathing, giving rise to this phenomenon. Or it could even be rarely, although we say most mothers will breastfeed properly, there could be the odd mother who may not have milk, right? So those could be the possible causes. So this is just to enlighten you as to how growth charts would be effective to pick up and then subsequently monitor and see whether your interventions have been correct. Let's move to the next scenario. We all work in wards, and when we work in wards, I believe it's not only treating the underlying illness, but looking after children, giving holistic care. So this is a baby who, I'll show you the growth chart in a minute, admitted with a febrile convulsion. Going into the social history, parents were estate workers, and the child was in the daycare center when the mother is at work. Clinical examination, not very remarkable, except that there was mild pallor and some depigmentation of hair. And this is the growth chart. You can, I believe, very clearly see this child, as I mentioned earlier, has grown very well until 6 months. And what is happening subsequently? There is fall off in weight, okay? And this, if you follow up later, will end up somewhere here. And look at the child's potential. He could have gone up right up to there, okay? So what information do you need when you see this or when you are presented with the child? And what interventions do we do? We are going to discuss that now. So how do you evaluate a child who is less than 2 years coming with poor weight gain? The feeding history is very important, right? It depends on what the age of the patient is, because there is nothing very much to find out if the child is being breastfed. Don't think so, because breastfeeding also, you need to find out whether the baby is getting sufficient milk. So if we are considering the previous growth chart, I think we need to find out whether this child has a regular meal plan. Is he on to sweets? Are the parents vegans? So therefore, the child may not be being afforded foods of animal origin. And when was solids introduced and how well is it going? If you look at the babies who are breastfed, we need to find out whether there is adequacy of milk, how long the mother is taking to feed the child, because a mother who has sufficient milk, and if the baby is quite active, would finish taking a feed in about 10 minutes. And rarely, if the baby is being formula fed, you may have to find out whether the formula feeding is appropriately constituted. And of course, the feeding environment and the feeding behavior. Because in our setup, whether we like it or not, there are many distractions. Parents sometimes do not feed children on hunger cues. There is significant positive and negative reinforcement that comes into feeding in relation to children. So what are the clues that tell you that there could be potential organic illness? If there is diarrhea, then maybe there is possibility of malabsorption. There might be underlying diseases like CF. Some children, they do take a lot of fruit juice and sugary drinks, and that could lead to diarrhea. If they've got abdominal pain, not interested, maybe think about constipation, gastroesophageal reflux. If they are vomiting very early, think about surgical causes, but otherwise GORD, food allergy, and oromotor dysfunction. Polyuria is also not uncommon, especially if it is associated with constipation. And then Shanal will definitely agree, this is one of the ways that renal tubular acidosis is likely to present in early infancy. And of course, diabetes. Frequent infections is another red flag, and that can happen because of immunodeficiency or CF. So when you have a child, how do we rehabilitate them? You probably will realize by now going through what I have told you before, that we cannot have plans universally. For each child, the plan has to be an individualized plan. And it will depend on at which state the child presents, whether the child is presenting with acute malnutrition or whether there is a moderate malnutrition, and how chronic, whether it's acute one or a chronic one. Whether there are underlying medical disorders which have to be managed hand in hand along with the nutrition. And of course, the needs of the child and the family. We need to understand that, as Professor Samanmali very clearly mentioned several times, the family, the parents, they play a crucial role. So the suggested management will include a plan that addresses not only nutritional, but medical, developmental, psychosocial, and behavioral factors. And the support of caregivers is critical. So what are the indications to bring in a child with poor nutrition to hospital? Because you know that most of these patients are likely to end up in our clinics, and then we need to decide whether we need to bring them into hospital or whether they can be managed as outpatients. So if there is severe malnutrition with a body mass index of less than 12, then they will need to come in. If they have got serious underlying intercurrent illness and they are very sick, they will have to come in. If features of severe dehydration is there, again, they will need hydration and acute management. On the other hand, there may be other instances where the child is at risk of harm or has been neglected. And if you see that your interventions outside are not working, then such patients will also be needed to be admitted. These are patients whom we had recently in our ward, and you will probably be able to appreciate the amount of weight loss. There is hardly any subcutaneous fat there. The child's chest is completely wasted. This is a child with an underlying problem. I believe that you can appreciate the child is on a NG tube to try and optimize nutrition. So having assessed the degree of malnutrition, the principles are that we need to calculate for catch-up growth, right? We need to calculate for catch-up growth. And to have catch-up growth, we require a diet of high energy. So the required catch-up growth is about 2 to 3 times the expected weight gain in a child, and roughly about 45 to 60 grams for a day in a 2-year-old child. So you should get your target energy intake, and that you can do by calculating the estimated energy requirement for a healthy child. Don't calculate for the child who is sick. You calculate for a healthy child who is of that age and the additional energy that is needed for the catch-up growth. It is not only energy that they need the other nutrients as well. So the provision of proteins, multivitamins, and so on are extremely important. So what is the energy requirement? You know that up to about 2 months, it's about 100 to 110 kilocalories, and it will drop to about 90 kilocalories between the ages of 3 to 5 months. And thereafter, it will stabilize to about 80 kilocalories per kilogram per day. So if the target is to make sure that you get an intake to permit catch-up growth, then you need to do your calculation. So the estimated energy requirement you can do by checking the median weight for the child's current length and then dividing that by the child's actual weight. So then you will have a calorie requirement that is required to get the child to grow. But of course, with illness, what happens? What happens? We have other confounding factors. There's always poor appetite. The child may not be interested because he's sick, disinterested in eating. There's also catabolic response of illness, which increases energy expenditure. So in spite of you giving something, if there is increased heart rate or there is increased respiratory effort, then the child will use up whatever that is given to keep the catabolic response going. They get started on intravenous fluids, and then during that time, they are kept nil by mouth, either because they're in respiratory distress. And again, what happens? We don't give calories during that time. Then they don't have enough complementary food because we don't, supply everything in the ward. And what is going to happen? To pacify the child, parents will start to breastfeed again. Children who are 1 year, 2 months, maybe 2 years in hospital, you see that parents restart breastfeeding. And also not only that, but give them other commercial food that is easily available, which can have a very bad influence on the child. In addition to that, with illness, we have lots of cultural taboos. There is cold foods, heavy foods, which parents feel should not be given to children. We should always try to overcome these taboos, because these will indirectly have a very negative effect on nutritional rehabilitation. Not only that, there are other challenges that we come across. Feeds are not tolerated well. And whenever we try to escalate feeds, either the child aspirates or he vomits. And then again, we go into periods of time where we have to go nil by mouth. Sometimes the child is too ill to take the normal diet, so therefore we can go into a liquid diet. There is associated gastroesophageal reflux, and sometimes, although we want to start the appropriate food, these are not readily available in the ward. There is sometimes not the best of commitment from the health staff. So similarly, whatever you start has to be sustained at home, because this child is not going to be in hospital all the time. When he or she goes home, the parents have to be able to sustain the same diet following discharge. So in the outpatient setup, when we manage patients with mild to moderate malnutrition, nutritional therapy would be the mainstay of management. We need to have dietary counseling to increase the intake and to avoid undesirable food, and also change the feeding environment. Now, in this background, ready-to-use therapeutic food can be used, and they should not be the only one we use, because that will give the wrong concept to the parents to think, okay, biscuits are the right way in nutrition, which is not the case. These are only to top up the additional nutritional intake. And the strategy should depend on the age of the child and the dietary preference of the child. And that is very important. And this is just to highlight how important energy-dense food is, because this is a major problem in our country, where people, when they start giving complementary food, tend to give very, very liquid diet or thin kanji, which is very low in calories. So the food has to be thick, and it has to have diversity for the child to eat. So what are the supportive strategies during outpatients? Vitamin supplements are important because you need additional vitamins for catch-up growth. And that is, of course, with appropriate nutrition. It's not the case of just prescribing vitamins when a patient or parents say the child is not eating. Appetite stimulants, research has shown, has not had any helpful place except in special circumstances, and change in the feeding environment has been proved to be useful. So mealtime distractions should be minimized, and mealtime should be relaxed, and social eating should be encouraged for children to enjoy the food that they're eating. And the child should be praised when they have eaten well, but they should not be punished when they have not. So ladies and gentlemen, just the take-home messages: management of poor weight gain should be individualized, and it will depend on the severity and chronicity of the undernutrition, whether there is underlying medical disorders and its management, and the needs of the child and the family. The support of caregivers is critical. Multidisciplinary approach, maybe with dietitians, speech therapists, and so on, whenever there is a need, is always useful. Regular follow-up will certainly lead to better outcomes. Optimizing nutrition in all the children we see is our responsibility. Thank you very much.
Thank you, Heshan, for that very comprehensive lecture. We can entertain a few questions from our three panelists. Are there any questions?
I would like to ask one question from Professor Saman Mali. Madam, I'm here. During the tea break, you were talking about a little bit about virtual autism. I think the audience would like to know whether there's really an entity called virtual autism and whether screen time and children, there's a connection between them.
Thank you, Patil, for the question. And I think there is a link to what Heshan was talking also. I mean, I had so many things to tell, but within that little time, I couldn't tell everything. So it's very common to see children with autism having features of, firstly, as newborns, they have breastfeeding issues, feeding establishment. We don't know why, but it is highly associated according to all evidence. We assume that maybe due to certain sensory issues like they may not be liking the taste or the smell of breast milk to start off with, or maybe the texture of the nipple. We really don't know. But it's a well-established factor. And the same thing happens at the time of weaning, right? So with weaning, they totally stop eating. So the best way that parents try to do it is, again at weaning, it's possibly the texture rather than the taste. So what happens is, because this is actually very authentic to Sri Lanka, the use of television to feed children. It is not something that is described in any of the autism literature in the entire world. I mean, I would love to do a study on this, but I have no time to do it. So then children are put in front of the TV because the parents are very scared of the midwife, because the midwife will shout at them at the weighing clinic, right? So that establishes a cycle where the children with autism love the screen